Splendid.
Neccs. Wow. Exciting, man.
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 Splendid.
Neccs, wow, exciting, man.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning to all. Welcome to our virtual National Emergency Critical Care Symposium 2021 entitled with the Crashing Critical Ill Patient, the Fundamental of Science and Philosophy. I'm Nur Fazliatul Azrim binti Farooq Shah.
And I'm Dr. Chen Wing Sing. It's a pleasure to be the master of ceremony for this 2 days event.
All right, Chen. Since this is our first virtual Nexus, is there anything that you want to share with the audience?
Of course, there are 3 important things that I'd like to share. Number 1 is that if there is any problem logging in, kindly contact Encik Fazli, which is our contact person at 019-757-0747, or log on to www.ipoems.org and go to the inquiry section. The second part will be that for questions, any questions in lectures, kindly drop them at the Q&A box. And lastly, do not forget our Kahoot session at the end of the event.
Okay, Chan. Now it's our time to introduce these 2 big names of Emergency Medical of Malaysia, which is Dr. Mahada bin Abdul Wahab and also Dr. Adi Osman.
Without further delay, let us go through the impressive background.
Thank you, Chen. Dr. Mahada bin Abdul Wahab is currently the National Head of Emergency and Trauma Services. He's also the Head of Department and Senior Consultant, Emergency Physician, Emergency Department of Hospital Kuala Lumpur.
Dr. Adi Osman, on the other hand, is currently the State Head of Emergency and Trauma Service in Perak, as well as Senior Consultant, Emergency Physician, ED Critical Care in Hospital Raja Pemaisri Bainun. Without further delay, let us invite Datuk Dr. Mahada and Dr. Adi Osman for welcoming.
I don't know who you are. I don't know what you want. I can tell you I don't have money, but what I do have are a very particular set of skills. Skills I've acquired over a very long career. Skills that make me a nightmare for people like you. I will look for you. I will find you. And I will...
Assalamualaikum and very good morning. Welcome to our Neccs 2001. With me now, yang berbahagia Datuk Dr. Mahada. Mahada, how are you?
Fine, great, Adi. Thank you very much. I think welcome everyone to to all the participants of Neccs 2021. This year is going to be a great year. It's not just that we line up hundreds of topics, which is of a very important significance. And on top of that, we're going to do virtual Neccs 2021. Yeah.
Well, and so as Dr. Mahada mentioned, we would like to welcome those participants for the first timer. We also like to welcome those who actually been with us for years and years. So we'll come back again and again. Next. So this Neccs is actually organized by Ipoh Emergency Critical Care Society, which is actually formerly known as Ipoh Emergency Medicine Society. So Datuk Mahada, what do you think? How is the Neccs for the last 4 Neccs that we have?
I think over the years, we already, firstly, we already have what we call hardcore followers. I think that's very important. Secondly, is that it's quite excited to see the conference grow from year to year in strength. It's not just in terms of the response from the participant, but more important, actually, the depth of the topic that been discussed, which is this is very important that reflecting the advancement of this particular topic in our country, especially. Yeah, I think we are actually very proud that this program has evolved over the years, actually, towards a very exciting frontiers. Okay.
Just for your information, this conference is actually endorsed by our success and also College of Emergency Physician. And we have a lot of topics that we're going to discuss. Okay, a lot of things that happen, right? And of course, there's a reason why we choose this specific, what I call it, theme, patching critically ill patient, the fundamental of science and philosophy. You have any comment about this?
Yeah, I think this is a very timely topic, especially during this pandemic time, where actually these are the most challenging what we call areas that need to be intervened or overcome for many of us. I think as a busy physician, even any other critical care physician that managing ill patient, this is what I call a cornerstone of our daily activities. And but importantly, actually, it's not just looking at the advancement. We go to the basics, some of the intervention that will be carried out. It's a great topic to have this year, and is very much pertinent, especially with regards to the current situation. Yeah.
Okay, Doctor, what it means actually now, the way we get the knowledge, right? Used to be a leading scientist, PhD student, but now it's actually most of the knowledge is actually people get from this Mina Muhammad, from this book. What is your personal opinion this fellow?
I think this is not just the challenge by us, but I think in this when we actually enter the information what I call millennium, the issues of knowledge which is easily accessible by many means actually is one issue, but importantly actually the issues of the what actually the knowledge that is actually of true values or have what I call importance, impact to our day-to-day practices. We can have Mamat and Mina actually to tell us the issues or provide us the knowledge, but this knowledge very much applicable based on scientific evidence. If it's not scientific evidence, but through a very valid consensus among the professional. I think that's the important aspect that we need to know inside out.
I think it's a great advice. I think for this Neccs, this is actually a program that we actually going to discuss for the next 2 days. We have two tracks, Track A and Track B. Now, basically, we're going to discuss about the emergency medicine related topic, in particular, the critical care topic that relate to the emergency department. And there's not much changes in the format. Okay. I know your guys, ED especially, we have a short attention span. So the lecture will be a short, concise, and sweet 20-minute presentation. We have a Q&A, which is you can actually look at the bottom on the right. There is a QA box. So you can ask questions to this QA box. And we're going to answer the question on real time, or we're going to send back to you through email. Right. So we have almost 1,000 participants for this conference. We have people from anesthesia, intensive care, for internal medicine, from emergency department, from district hospital, and also those medical officer, assistant medical officer, and stuff. So, is there any difference in terms of population this time, Dr. Wanda?
I think this is very rich. I think this richer and richer, as I said, over the years. The participation is not just meant for emergency physician, but many other players actually managing ill patient. So I think this is very important because managing ill patient require whole spectrums of what we call profession and professionals actually in order to ensure the best outcome for our patient. So it's great to see that as well. Yeah.
Right. Well, we like to thank personally to thank these four industrial partners that is actually help us in terms of finance this conference. Right? And of course, this conference can actually be followed through the Twitter. This is our Twitter hashtag Neccs 2020 and 21. All right. And Dato, any last comment from you? Advice?
Nothing much. Importantly, actually, it's great to have this conference again this year. I think to all the participants, sit back, relax, enjoy the what I call presentation. And for the committee members and for the speakers and all that, I think we would like to thank your contribution and valuable input in ensuring this Nexus is a great success to many. I think that's all from me. Hopefully that all the participants will enjoy and benefit from the knowledge that we're going to be delivered in this particular conference.
Right. So guys, see you in the next 2 days.
All right.
Goodbye.
Okay. Bye-bye.
1, 2, 3. Assalamualaikum and very good morning. It's actually a great honor for me to introduce this particular person. He's a founder of Emergency and Medical Services, Trauma Services in Malaysia, father of Emergency Medicine in Malaysia, a previous head of service, Emergency and Trauma Services Malaysia, and currently a president of MASTEM. So he's also a past president, in fact, the first president, College of Emergency Medicine, Academy of Medicine Malaysia. So guys, without further ado, I would like to welcome Yang Berbahagia Datuk Sri Professor Dr. Abu Hassan Ashari Abdullah.
Bismillahirrahmanirrahim. Assalamualaikum, salam sejahtera, and very good morning. First and foremost, I'd like to welcome every one of you to the National Emergency Critical Care Symposium for the year 2021. And this morning, I've been invited by Dr. Adi and his team to present in the special invitational lecture, which is named after my name. And for that, I'd like to thank Dr. Adi and his team for the kind gesture of inviting me. And I'm doing it with great pleasure and honor. The theme for the National Emergency and Critical Care Symposium for this year is entitled Crashing Critically Ill Patient, the Fundamental of Science and Philosophy. First, I'd like to just say to every one of you that I have prepared a lecture in relation to this theme. And for those who have not known me or haven't met with me, I was a former head of Emergency Medical and Trauma Services for this country, for the Ministry of Health Malaysia, and presently holding position as a council member of Malaysian Medical Council, and also the Deputy Master of Academy of Medicine Malaysia. Now, relating to the topic today, crashing critically ill patient, the fundamental of science and philosophy. Let me begin by expressing to you my intention of elaborating this topic, stating first and foremost the definition and terminology. I will delve a bit about the fundamental of science and philosophy, and the main component of my lecture will be the conceptual framework of the management in emergency department, in emergency medical and trauma services. And of course, I will address the management of crashing patient in the current concern, that is the COVID-19 pandemic. I will be turning lesson identified into lesson learned for the legacy of this lecture before I conclude and summarize. Well, let's begin by putting everyone in the same page, putting us in the correct perspective of this crashing patient is actually a process of rapid deterioration of patient's hemodynamic, physiological, and metabolic system, where this rapid restoration of tissue perfusion and oxygenation is urgently required. Now, this crashing critically ill patient, either due to medical or trauma causes, is actually a process of collapsing vital and major physiological system, hemodynamic, circulatory, cardiovascular, and metabolic system. Now, this is important for us to understand. If the intervention is not done appropriately in good time, it will lead to total system failure, multiple organ system failure, and finally mortality. Now, in the aspect of fundamental of science, this specialization that underpin all scientific and systematic basis from the microbiology to the cellular, tissue, and genome system to the data science, nature, and characteristic that will translate into clinical manifestation of the disease process is the philosophy that we will have to understand. Like I said, the philosophy based on the fundamental nature and the knowledge, reality, and existence, as well as the theory and the attitude, will act as the guiding principle for all our action and performance. Ladies and gentlemen, please understand the hemodynamic instability relating to circulatory collapse, decompensating shock, hypoperfusion, cardiovascular failure, where the pressure in the circulatory system is really low and weak to enable adequate perfusion and oxygenation to the vital organ and physiological system. Now, if we look into the cellular level, the impaired oxidative metabolism due to hypoperfusion will lead to energy failure, will lead to cellular injury and death, and definitely multiple organ dysfunction. Now, I will actually put to you that there is these clinical features that we all have been trained to identify. Unfortunately, this is not so classic. I'm not going to bore you with this because the issue about the whole mechanism of the hemodynamic perspective in relation to the regulator include venous rhythm, myocardium contractility and its function, pre-capillary arterial resistance, capillary exchange circuit, and the whole works will be affected by the crashing critically ill patient physiology. Now, let me first and foremost remind everyone, we tend to relate hemodynamic instability to shock. No, shock is a medical condition with many types: cardiogenic, distributive, hypovolemic, and so on. But hemodynamic instability is the one that we are not talking about. Now, this is really to make everybody understand that crashing critical ill patient is not necessarily shock. However, the whole component of shock will be part and parcel of the whole process of the physiology of crashing critical ill patient. Now, let me explain again. You have to define the metabolic response of crashing critical ill patients for us to actually intervene the disease process accurately. Now, we know about at phase within 24 to 48 hours, which is a reconstruction of body normal tissue function in effort to protect hemostasis. Unfortunately, if the challenge or the hemodynamic instability continues, then it goes to the flow phase and catabolic phase. Now, this is what we call the substrate flow or hit and run. Now, really, the process of building up the system again under the anabolic phase really relate to our intervention. Now, this phase may not occur. Unfortunately, again, in emergency medicine, ladies and gentlemen, the patient can present to us with any of this clinical manifestation of the three phases. So we cannot just hope to see the patient at phase, flow phase, we wouldn't know. Now, that's the reason why we must understand what are the modulator for this system response. Endocrine system response is very important. Overstimulation, what we call adrenergic stress and adverse effect, when massive vasoconstriction happen, is something we must recognize. And everybody is fully aware in this kind of challenge, the immunological response will be affected. I will talk to you all again about the metabolic response to this particular situation to understand the whole process. Well, hormonal response, systemic inflammatory response syndrome are all the features of which when we do investigation, we'll be looking for it. Now, I'm sure we recognize the system which is activated, what we call the collapsing circulatory system activating sympathetic nervous system, what we call the body acceleration device, that manage stress response is very important for us to recognize. You see, the stimulation of catecholamines or adrenaline will lead to all the blood flow readjustment, ranging from the large muscle group, lowish gastrointestinal system, what we hemodynamic system that can even cause ischemia, and of course the shunting of blood away from the skin are all the clinical features that we will see. I just want to put a point to everyone that insulin resistance is a big challenge during time when we have this metabolic response, and this is why catabolic phase will come very soon if we don't intervene. Now, I'm going to just touch on this quickly. The hepatic response, skeletal muscle response, breakdown of skeletal muscle, and all these are all the features when they present to us in the emergency department. Rerouting and redirecting of blood flow to vital organ is very important. Now, if you look at this, when we do this shunting of fluid, it may affect some inevitable problem, especially the fluid will go to the third spaces because increase in capillary permeability. Now, what happened at the cellular level is what we call the anaerobic metabolism. Now here, I just want to emphasize the point that very quickly when we have anaerobic metabolism, the waste product of anaerobic metabolism, carbon dioxide, water, lactic acid, will cause, we know it very well, metabolic acidosis, which will therefore complicate matters. Now, little cascade of event, little triad of death, acidosis, coagulopathy, and hypothermia is a feature that will appear at the emergency department when they arrive. Ladies and gentlemen, I'd like now to proceed to make every one of us understand in the nature of emergency medical and trauma services is completely different from the bedside clinical practices. In emergency medicine, have got case presentation which is undifferentiated, undiagnosed, late stage, and time critical. Every second matters. Ladies and gentlemen, the time critical aspect, which is crucial, requires highly skilled personnel to provide early management. You know very well, heavy duty, sophisticated medical intervention, equipment, and team effort is crucial. I'd like to re-emphasize the point that early co-management strategies involving the relevant department must be instituted very soon. Emergency department is overcrowded, busy, and unfortunately, the situation right now with COVID-19 pandemic complicate matters even more. Undifferentiated late stage presentation of critical ill patient make it very difficult to recognize because it's preceded by a period of physiological deterioration, therefore early sign usually missed. This is important. I'd like to emphasize one very important point. Chain of response, thinking in action, what we call consequentialism is important. We cannot be chasing for diagnosis. We cannot be waiting for result. In the total clinical phase, recognizing syndromic interpretation with focus history and rapid sequence examination vital signs become most important. We are hopeful that the first responder of this patient were able to accurately record, document, and serial of reading, not one early intervention is instituted as soon as possible. What we call the life-saving intervention. Now, we appreciate the fact that we have some clinical and bedside investigation that have to be done. Now, all this must be done at the same time, what I term as consequentialism. Now, definitive investigation and intervention for such cases hopefully will be done together with the relevant department. Now, this is something I would just want to make a strong point that essential skill for the frontline clinician really about able to have sharp clinical acumen, cool and collected, having this thing called the Gestalt psychology, and I like to say, number 5, pattern recognition become very, very important. Now, let me explain to you in emergency medicine, in order for us to have the clinical approach, method for the razor-sharp decision-making, we are talking about the patient in totality. We're talking about the person, the affect, the body language, sound, and this relate to syndromic interpretation. ladies and gentlemen, pattern recognition is very crucial. What is pattern recognition? It is a cognitive process that matches the information from the stimulus with the information retrieved from our memory. The more experienced we are, the more challenges we face, the more what we call content in our cognitive box. This is where, when we talk about the Midas touch, the good super clinician, they're almost like genius who actually can look into one case without even touching, without even examining, using their gossip psychology. Then they can make diagnosis. And this is so important for us to relate to what we call the clinical bedside investigation, to relate to something that we must be able to do without to chase for diagnosis. Now, if you look at this, the clinical examination investigation using ultrasound have become a very, very important feature. And this feature is now a culture in emergency medicine. Now, let me explain to you about this particular diagram. Now, if you look at the pattern recognition concept, when we see a patient, the presentation, listening to the patient's history, it activates our senses. It goes into our brain, what we call the cognitive box. That's where we hope to have Gestalt psychology. Now, with focus history and systemic examination, we can therefore institute package management. I repeat what I say. In the final analysis, the balancing between combination of human skill and enabling technology will be able for us to intervene accurately. Okay, my agenda today in the management of critically ill patient, which is exsanguinating and collapsing, talk about damage control resuscitation. Although historically, damage control resuscitation relate to a lot of trauma situation, but now when we talk about the visionary extrapolation of damage control resuscitation principle, it includes all crashing critically ill patient. What it really means is that we have damage control surgery if it's required, early initiation of blood product transfusion, permissive hypotension, and so on and so forth are all the components. Now, let's have a look at this. If there is a need for first look surgery, arresting major hemorrhage, it has to be done immediately. If there is a need for abbreviating operative intervention, shortening the duration, it has to be done. However, most importantly, fluid therapy becomes so crucial. I will re-emphasize the point that fluid therapy doesn't mean bombarding the patient with all the fluid. We must do coagulation management. We must mention a proper balance between fluid management and actually what patient require. Now, if you look at the early blood product transfusion, that is a fashion nowadays. We don't give whole blood. And I'm sure you appreciate the fact that there is a need for us to intervene to manage hematologic stability. Now, let's have a look at this. In the damage control resuscitation, we talk about immediate arrest or temporarization of ongoing hemorrhage by vessel ligation, hemostatic powder, and this has to be mentioned that it has to be done immediately. This is why co-management in the relevant department become important. I mean, the orthopedic, surgical discipline must come soon. Otherwise, we will end up with continuous ascending waiting circulatory system. Of course, airway ventilation, hemostatic resuscitation. Now we bring in pharmacotherapy very early phase. Tranexamic acid, factor 7 recombinant, and so on, so on become important feature of early intervention. Ladies and gentlemen, please understand, permissive hypotension is quite relevant because, as you know, with capillary permeability, a lot of fluid will flow to the third space, and that complicates matters. Now, the goal for blood pressure for this patient is only about the mean arterial pressure of 40 to 50. And this is why the systolic blood pressure need not be normalized, and we can make it around about 80. Damage control resuscitation also requires us to intervene at the pre-hospital level. Now, I'm not going to bore you with the detail. Please appreciate the fact that when we identify and sequencing situation, it has to be arrested immediately. Now, let's look at quickly about crushing injury. We know this very well. Most of these patients end up in emergency department after 1 or 2 hours. Nothing has been done at the site. Now, this is why in the early phase of crush syndrome management, quickly we must realize that the mechanism that release the breakdown product due to cellular destruction increased capillary permeability, rhabdomyolysis is the feature of crush injury, of which we need to understand that kidney problem, nephrotoxic, cardiovascular system, and in fact, there is this thing called the smiling death, where initially they are fine, they are smiling, they're happy. Suddenly, because of all this toxic product, the whole system crashes. Now, quickly, I just must mention it again to everyone. Crush syndrome requires a proper intervention, which I won't be able to go into the specific. Intravenous administration of sodium bicarb and ligation and all those things may be considered. There are a lot of differences between European and American system, but I will rest my case now to mention that we must appreciate the need to intervene. Now, the next thing that I'm going to talk about is the conceptual framework of managing crashing patient during COVID-19 pandemic. Ladies and gentlemen, let's don't deny the fact that pandemic COVID-19 threatens human survival, the well-being of human dignity, human security. The medical fraternity is facing difficulties in managing critical ill patient while making effort to reduce spread of COVID-19. What we call dual hazard, double jeopardy. We try to respond and manage one hazard. Unfortunately, it exacerbates the other. You know this. Nowadays, COVID-19 is among us. It's sporadic. It's no more cluster because it's all over the place. Number two, we have this risk assumption that about 5 to 10% of the victim can be COVID-19 carrier, and 5 or 10% of the frontliners can be asymptomatic transmitter. Unfortunately, resuscitation activities and intervention increase the risk and susceptibility. We know the resuscitation area is enclosed space, crowded, and with body fluid contamination. Now, recently, WHO recognized that the high risk vulnerability related to aerosol producing procedures, in fact, is airborne. Now, we know in resuscitation is close contact, body fluid contamination, teamwork, and therefore, we have to appreciate resuscitation must be done. Now we know that the use of power air purifying respirator to enable us not to breathe in the polluted air, which is COVID-19 infected, is something that we have to appreciate. Now, if you look at this, there are many methods we have to do resuscitation safely. And please appreciate the fact that inhalation of very fine respiratory droplets, aerosol, and disposition of respiratory droplets, particle around the resuscitation environment is so what we call high risk for the frontliner. Now, if you look at what we do, we humans touch our face, eyes, and mucous area at least 25 times per hour. Despite having all the donning, we still move our hand to touch our face. This is being human. Now, that will increase our risk. Now, please appreciate the fact that respiratory fluid are all over the resuscitation environment. Now, as I said to you, infectious person exhaling virus within 50 minutes indoor, increased viral concentration, crowded high activity, and even for that matter, transportation in ambulances increase the risk. This is why power air purifying respirators are required. I'm not going to talk to you too much about aerosolization due to CPR. It is a well-known fact. Now, please appreciate this fact about the variant of concern. The most brutal is now what we call the Delta variant that originates from India. Now, this, unfortunately, is a challenge. It is 60% more transmissible than Alpha variant. Delta, unfortunately, also some of the vaccine will not touch it. It is the most contagious, fastest, fittest coronavirus and more lethal. You know what it is all about? Today, in the daytime, you are okay. Suddenly, at night, it rapidly go to the lung, and without any respiratory warning sign, patient will have what we call decompression of the oxygen level. Now, this is what we term as happy hypoxia. Ladies and gentlemen, please understand the Delta variant now, is not about us washing hands, not about us using sanitizer all the time, because it is in the air that we breathe. The COVID particle can stay in the air for 16 hours or more. Therefore, ventilation is important. That's precisely I invented this thing called the all-time hyperlight antimicrobial ultraviolet light C. Now I did that because it is to disinfect the air without using too much of chemical, of which those chemicals can cause problem to human lung. Anyway, now UVC hyperlight radiation generates high energy that can destroy the protein coating of the SARS virus or the coronavirus. This is my invention, presently used in many hospitals, including Selayang, Sungai Buloh, and some other hospitals around the country. It is about having all-time hyperlight antimicrobial ultraviolet C, either in a air disinfection system within the area or in the aircon duct. For that matter, now we have even in the ambulance. Now, recently, the minister announced the ministry seeking 500 negative pressure ambulances, although he was misquoted. But most important, look at that. The type of ambulance is also fitted with HEPA filter ultraviolet light. Now, this is something which I really am promoting. With the enclosed space in the ambulance, the risk of contracting COVID from the patient is very high. So yes, I promote the use of HEPA filter as well as ultraviolet C in ambulance. Now, frontliner is now going through severe burnout. I really think that we have to do something. What do we need to do? First, we must appreciate what we call the Peltzman effect. Peltzman effect is actually where people are taking risk because they have been vaccinated. Now, they can be, vaccinated individual can be a asymptomatic transmitter. They start having increase in risky behavior, decreasing the infection in vaccinated population become very difficult. I just want to mention the point about pandemic fatigue. I think most of you realize that people are now depressed, psychological challenge, and this is why we have to be careful. Now, turning lesson identified to the lesson learned, let me just give you some important point. Crashing critical ill patient is a very complex clinical condition. High-level clinical skill and competency to provide early prolific intervention is important. So specialists must be involved early. We cannot muck around. Now, clinical presentation of crashing critical ill patient in emergency medicine, even for the matter at the pre-hospital care, could be very complicated. Now, therefore, razor-sharp decision-making, prolific intervention must be instituted. Clinical manifestation of crashing patient again have been presented with different phases. As you heard just now, I talk about metabolic response. Therefore, early, highly skilled clinician with the involvement of relevant department in the aspect of co-management is required. Now, the need for us to provide damage control resuscitation to arrest asynchronating crashing clinical scenario is crucial. Damage control resuscitation principle must be initiated deliberately. If need be, early procedure and technical intervention should be done, arresting bleeding, early operation. Now, let me remind everyone, during COVID-19 pandemic, primum non cere, which means do no further harm. Take all precaution for human, frontliner, patient, environment. Please institute air disinfection and use equipment like PAPR. Reducing the risk of transmission from airborne viruses, aerosolization, as well as droplets in critical care environment is important. Therefore, to make sure risk, infectivity, and susceptibility should be brought to the lowest, and I promote the use of all-time hyperlight antimicrobial ultraviolet light, which is recognized by WHO. Now, in summary, let me remind everyone that crashing critical ill patient will remain as a huge clinical challenge. Early recognition, investigation, intervention of this complex situation at emergency department must be acknowledged. Please recognize the fact that we cannot muck around. Early specialist level involvement and integrated comprehensive teamwork. This approach between emergency medical staff and the relevant department must be done as the critical success factor. Now, COVID-19 pandemic created bigger challenge. For the dual hazard and double jeopardy situation, complicate matters even more. I just want to again re-emphasize the point that this huge clinical challenge requires us to manage our frontliner. Frontliner wellness must be instituted for what we call institutionalization of a care and wellness for them. What do we need to do? Which we haven't done well. Infectious disease prevention, COVID-19 screening must be done regularly. Now, critical incident stress management must be instituted, and we must take care of those who are depressed. You know that psychological mental status challenge is real. Now give them leave, let them recover from their challenges, those who have been affected by it. As you all know now in Malaysia, we have all this, what we call the career path management. I think we know about the impending intention of doing what we call striking or whatever. Well, rather than do that, I hope the government can pick up the concept of career path management for frontliner and give them permanent posts for the young doctors. I'm going to conclude by reminding you that COVID-19 pandemic impacting global health, economy, and humanity, changing the way of life of mankind. However, let me remind you, if we can't control the situation, we have to challenge ourselves to control the way we respond. So we should not stop human activity. People should go to school. People should work regularly. But we have to manage human behavior to prevent the COVID infection. Finally, what future lies ahead of us with COVID-19? Let me give you a reminder. This is what we call, this too shall pass. Inshallah, in Bahasa Malaysia, ini pun akan berlalu. Whatever you are going through right now will soon pass. And as Allah firman, truly with hardship come ease. Well, I'm sure you know about the story of a very wise man. He been asked by the king to write a very important message in the ring. So he wrote in the ring this, that this too shall pass. So if you look at the ring every time, when you are happy, remember, this too will pass. When you are sad, remember, this too will pass. No one beside Allah can rescue a soul from hardship. Ladies and gentlemen, thank you. Thank you very much for your kind attention. I have done it with great pleasure in honor of this special invitational lecture, which is named after mine. Thank you. Thank you very much.
Assalamualaikum and a very good morning to all the participants. We are about to start our first symposium of the day for virtual Neccs 2021. So I'm going to be the chairperson for today, and for the first symposium we have 6 speakers. So I will introduce one by one. Let us start with the first speaker, Professor Dr. Sabaria Faizah Jamaluddin. She is currently a professor of emergency medicine from University Technology Mara. She also hold a post as a president for the Malaysia Resuscitation Society. And currently Dr. Sabaria obtained a medical degree from University of Alexandria 1994, and she obtained her master's in anesthesia in the year of 1991. She is previously our national advisor to Ministry of Health Malaysia for Emergency Medicine and Trauma Services till November 2018. Our second speaker is Dr. Teo Art Hyo. Dr. Teo is a consultant emergency physician from Hospital Pulau Pinang. He also hold a post as an honorary senior lecturer for Penang Medical College and involved actively as an editorial board member for multiple types of journal. And he is actively involved in Penang Resuscitation Committee, and his special interest basically focus on resuscitation and pre-hospital care, and also development from modules of training in Ministry of Health. Our third speaker is Professor Dato Nik Shamuddin Nik Abdul Rahman. Professor Datuk currently hold a post as a Deputy Director, Infrastructure and Asset, and also as a Senior Consultant and Clinical Specialist in Emergency Medicine, Hospital University Science Malaysia. Professor Datuk obtained his medical degree from Glasgow University in 1994, followed by Master in Emergency Medicine in USM in the year of 2002. And he obtained his Clinical Fellow in Emergency Medicine from Edinburgh in the year of 2006, followed by PhD in Bioinformatics USM in 2016. His special interest basically focus on health informatics in emergency medicine and various sub in emergency medicine itself. Our fourth speaker is Professor Dr. Philip Turan from United States. He is currently a clinical instructor of emergency medicine, an associate director for the Center of Resuscitation Science, director of research division of emergency ultrasound, and also a co-chair for the Resuscitative TEE Collaborative Registry in the Department of Emergency Medicine, University of Pennsylvania. He is trained in emergency medicine and obtained his fellowship in point of care ultrasound at Mount Sinai Hospital. His special interests focus on critical care ultrasounds, transesophageal echocardiography, and cardiac arrest resuscitation. He is also a founder, faculty member of Resuscitative TE project, and also a co-chair of the Resuscitative TE Collaborative Registry and a course director for the above workshop. And Dr. Roslanuddin Salahuddin is an emergency physician from Hospital Sultan Abahiyah Al-Usta. He obtained his master in the year of 2012 from University Science Malaysia, and currently recently obtained his fellowship in emergency critical care and emergency critical ultrasound. And his special interest is focused on evidence-based medicine and critical care ultrasound. And the last speaker for the first symposium is Dr. Ridwan Datuk Muhammad Isa. Dr. Ridwan is a Deputy National Head of Emergency and Trauma Services. He is also a State Head of Emergency and Trauma Services for the State of Selangor, Head of Department and Consultant Emergency Physician in Hospital Ampang. Dr. Ridwan obtained his medical degree from UKM in the year 1996 and followed by Master in Emergency Medicine from USM in the year of 2003. And Dr. Ridwan is actively involved as a coordinator in various national and international emergency medical service coverage. So let us not delay. Let us start our first symposium by first speaker of the day, none other than Professor Dr. Sabaria Faizah Jamaluddin. Professor, the floor is yours.
Assalamualaikum warahmatullahi. A very good morning. I am Professor Dr. Sabaria Faizah Jamaluddin from the Department of Emergency Medicine, University Technology Mara. First of all, I would like to thank the organizing committee for inviting me to the Nexus. It's always a pleasure for me to attend this Nexus and to give a bit of my thoughts, either in person or even virtually as we are doing today. I have nothing to declare. I'm currently the president of the Malaysian Resuscitation Association of Malaysia. I'd like to cover the adult basic life support, adult advanced life support, post-arrest care and neuroprognostication, pediatric life support, both basic and advanced, neonatal life support, a bit on obstetrics, and just a bit on resuscitation. What I'm presenting today are mainly the recommendations from ILCOR. ILCOR is the International Licensing Committee on Resuscitation. It was founded in 1992. It's made up of various resuscitation councils and heart foundations, which include the Asian Resuscitation Council. The main function of ILCOR is to improve resuscitation science through evidence-based review of research relevant to cardiopulmonary resuscitation and emergency cardiac care. A new set of guidelines are released every 5 years, starting 2000, and every year there is an ILCOR summary starting from the year 2017. In my presentation today, I'll be covering mainly the ILCOR treatment recommendations with some additions from the American Heart Association, AHA. Unfortunately, I will not be covering the evidence and the science because time does not permit. However, you can read the 2020 ILCOR consensus on CPR and ECC science with treatment recommendations in either resuscitation or circulation journals. The science and treatment recommendations are reviewed by the resuscitation councils to come up with the guidelines that they think suitable for them. HA came out with their guidelines in October 2020, while ERC in March 2021. Inshallah, the Malaysians NCOT, the National Committee on Resuscitation Training, headed by Dr. Rizwan, will come up with the guidelines in October 2021, inshallah. The key messages of this recent guidelines is not many. Most recommendations remain unchanged from 2015. It's mainly updated or reaffirmed by further evidences, and then there, of course, there are very few that are actually new, and some recommendations are strengthened by evidence. We are all very familiar with the chain of survival that the HAA comes out with. In 2020, they've added another chain, that is the recovery and rehabilitation. And as we all know, rehabilitation is very important in the holistic care of our patients. Let's start with the adult basic life support. The lay patients should initiate CPR when presumed cardiac arrest because the risk of harm to the patient is low if the patient is not in cardiac arrest. So, if a patient thinks that the patient is in cardiac arrest because the patient is not breathing or agonal breathing, he should start. He should not be worried that this patient is not in cardiac arrest as to come harm from the patient, because evidence have shown that if CPR is done on a patient who is not cardiac arrest, there's very little risk of injury to this patient. Now, if you're a lone bystander and there's a cardiac arrest, you should take out your phone, put on silent, put on the speaker phone, dial your 999, and then talk to the call taker over the other side, and then he will assist you in doing the CPR. So do not waste time trying to call and take it for a long time. Bystanders who are trained and able and willing to give rescue breath and chest compressions should do so for all adults in cardiac arrest. So if you're willing to do resuscitation or willing to do rescue breaths for patients, please go ahead if you're trained to do so. But if you're not willing to do so, hence only chest compressions is good enough. A short period of CPR until the defibrillator is ready for analysis in an unmonitored patient. So if you have if the defibrillator is not near to you, you should start the CPR first until the defibrillator is there to give the analysis of what the rhythm is with this patient. Always put this patient on a firm surface, but if this patient is on the bed, do not move the patient to the floor because that will take a bit more time. Just keep this patient on the bed. And if the bed have a CPR mode which hardens during, if you switch on the mattress will harden. If you switch it on, it should be activated. Let's now move to the adult advanced life support. The first things we'll be talking about are the vasopressors. Of course, adrenaline still remains the main drug during CPR. For unshockable rhythm, adrenaline to be administered as soon as possible during CPR. So this is an update. So an unshockable rhythm, give adrenaline as soon as possible. In shockable rhythm, adrenaline to be administered after initial defibrillation attempts are unsuccessful. And you suggest against giving vasopressin to adrenaline during CPR. So vasopressin is again out. What is new is the addition of lignocaine in the armamentarium of drugs for patients with refractory ventricular fibrillation or ventricular tachycardia. So you can use either amiodarone or lignocaine in such cases. So you are familiar with this, and the additional is amiodarone or lignocaine to be given. Airway management suggests using the back valve ventilation or advanced airway in any settings. But if you want to use the advanced airway in out-hospital cardiac arrest, use it if you have a low trachea intubation success rate. So if you're not very good at intubating, if you want an advanced airway, use the supraglottic airway for out-hospital cardiac arrest. For in-hospital cardiac arrest, you can either use the supraglottic airway or the tracheal intubation. But whatever the technique that we use, the back valve mask ventilation is also a very good technique. This is new. The intravenous versus the intraosseous. It suggests that IV access as compared with intraosseous access as first attempt for drug administration during cardiac arrest, which means that if you should attempt IV first before going for the IO, and you should attempt the IO when the IV access is not feasible. Next is the extracorporeal CPR versus the manual or mechanical CPR. Extracorporeal CPR is putting the patient on the bypass. So it recommends that CPR may be considered in selected patients when the CPR is failing in settings which can be implemented. So if the patient is in the theatre, if the patient is in a cath lab and you have the bypass ready, you can give the eCPR for these patients. And there's a lot of publications coming out, especially in Asia and in Japan. On double sequential defibrillation, some people use it for refractory ventricular fibrillation. It's used as two shocks given via two defibrillators with pads at different positions. However, the treatment recommendation is suggest against routine use of the DSD strategy. On the ventricular fibrillation escalating protocol, the first shock, if your first shock is not successful and the defibrillator can deliver higher energy, it is reasonable to increase the energy for subsequent shocks, which means that if your defibrillator has, for example, 200 joules, 300 joules, and 360 joules, you can keep increasing it if you want to. So they're not against it. Physiological monitoring on quality of CPR, it may be reasonable to use physiological parameters such as arterial blood pressure and end-tidal CO2 when feasible. End-tidal CO2 has been shown to be a good indicator on the quality of CPR. An increase in ETCO2 may denote ROSC, while low ETCO2 may denote an inadequate circulation or compression. Ultrasound, only skilled operators should be to use focus. It should not prolong interruptions in chest compressions. You have only 5 seconds hands of time. It's mainly used to diagnose reversible causes such as tension pneumothorax or cardiac tamponade, and you should not use focus for prognostication during CPR. Just something about prone CPR. If this patient is in prone position and this patient do not have an advanced airway, you have to quickly put this patient in supine position and begin CPR. However, if this patient has an advanced airway and in prone position, you can start your CPR in the prone position and give the shock in the prone position. The location of compression is 2 hands over the T7 level at the level of the inferior border of the scapula. And the location of the defibrillation pads is either the posterior apical or the posterior anterior. Once the patient has return of spontaneous circulation, we move on to the post-cardiac arrest. I will not be talking on the management of post-cardiac arrest after RSC, but only some points as highlighted in the treatment recommendations. The first recommendation is the oxygen dose after RSC. They suggest that the use of 100% oxygen until the saturation or the partial pressure can be measured in adults with ROC. Always avoid hypoxia and, of course, also avoid hyperoxemia. Temperature control. Targeted temperature measurement are carried out in many places, including in Malaysia. It is recommended for patients who remain unresponsive after RSC. You target the temperature to between 32 degrees to 36 degrees for at least 24 hours and avoid this patient having the fever. Neuroprognostication is recommended that it should always be undertaken by using multimodal approach because no single test has sufficient specificity to eliminate false positive. Use many tests, and neuroprognostication should be performed no sooner than 72 hours after return to normal thermia, and prognostic decisions should be based on multiple modes of patient assessment. Let's quickly move to pediatric BLS and ALS. For breathing, this is something about updated and reaffirmed. For infants and children with a pulse but absent or inadequate respiration, it's reasonable to give one breath every 2 to 3 seconds, which comes about to 20 to 30 breaths per minute. Before that is one breath every 6 seconds. So while performing CPR in infants and children with an advanced airway, you can also give the rescue breath 2 to 3 breaths per second. That's again 20 to 30 breaths per minute. Adrenaline infusion is also recommended to give early from the start of chest compression. And about something very new is among infants and children with hypotensive hemorrhagic shock, following trauma, is reasonable to administer blood products when available instead of crystalloid for ongoing volume resuscitation, which is similar to recommendations to adult trauma patients. Now, in septic shock, there's quite a lot of new things. What is updated is that to administer fluid bolus about 10 to 20 ml per kilo with frequent assessment. Before that, just mentioned 20 ml per kilo. And what is new is infants and children with fluid refractory septic shock. It's reasonable to either to use adrenaline or noradrenaline as initial vasoactive infusion. If there is adrenaline or noradrenaline is unavailable, dopamine may be considered. And for infants and children with septic shock, unresponsive fluids requiring vasoactive support, it may be reasonable to consider stress dose corticosteroids. For neonatal resuscitation, every birth should be attended by at least one person who can perform the usual steps of newborn resuscitation and initiate positive pressure ventilation, and whose responsibility is the care of one of the newborn. So you need at least one person who is capable to do PPV for delivery. And for babies requiring vascular access at the time of delivery, the umbilical vein is recommended route. If IV access is not feasible, it's reasonable to use the IO. So this is again a new recommendation. For obstetrics, these are the new recommendations because pregnant patients are more prone to hypoxia and oxygenation, and airway medicine should be prioritized during resuscitation from cardiac arrest. So for the pregnant lady, oxygenation and airway medicine becomes very important. Because of the potential interference for maternal resuscitation, fetal monitoring should not be undertaken with cardiac arrest. We don't want to spend time putting on the fetal monitoring. And we also recommend targeted temperature management. And during targeted temperature management, it is recommended that the fetus be continuously monitored for bradycardia and potential complications, and with the obstetrics consultation. What about in COVID times? Should we perform CPR? Should the bystander perform CPR? Should we perform CPR in the hospital? Is CPR an aerosol-generated procedure? All the recommendations has given international guidelines, including our NCOT. So the main concern in CPR is it involves many aerosol-generated procedures. During chest compressions, back valve mask ventilation, tracheal intubation, and there are numerous healthcare workers who work close proximity with each other and with the patient. So for the layperson, if there's a cardiac arrest in this COVID era, you call your 999, you wear the mask, you cover the patient's mouth and nose with a mask or with a cloth, do hands-only CPR, and defibrillate this patient when possible. And for the in-hospital cardiac arrest, ideally you should use the defibrillation pad so that you are quite some away from these patients. Always wear the proper PPE, make sure you have the proper equipment, have a filter for your back valve mask ventilation that they can use in the hospital care. I'm sure you have designed a closed circuit resuscitation and intubation set, which will decrease the aerosol operating procedures. Please follow the recommendations as given. NCOT has come up with the recommendations, and there's also recommendations by NCOT in the pre-hospital service, and the Malaysian Society of Intensive Care has also come up with the recommendations in the critical ill patients. In summary, ladies and gentlemen, there's no major changes in the 2020 guidelines. Most recommendations are strengthened and updated from new evidences. Early high-quality CPR in out-hospital cardiac arrest, in-hospital cardiac arrest, and early defibrillation remains the cornerstone of early resuscitation. All the life support, post-cardiac arrest care, and prognostication management should be based on good science and evidence and reviewed in a timely manner. With that, I'd like to thank again the organizing committee, and please stay safe. Assalamualaikum warahmatullahi wabarakatuh.
Good morning, everybody. I'm really happy and honored to be able to join you guys for this virtual NACCS 2021. Thank you to the EPO team for making this the best conference possible again this year. I have no conflicts of interest. This lecture is pitched for the Emergency Department Medical Officer and EM trainee. The topic describes a common situation that occurs daily in our ED, that in assessing the critically ill patient, and if I'm done with A and B, what comes next for C? Let's jump right in. The first question that we should really be asking is, should we really have started off with A and B? Now we know that for out-of-hospital cardiac arrest with a presumed cardiac origin, this should not be so, and C should come first. We also know now that in exsanguinating external bleed, C, arresting the bleed, takes priority too. But I think it also applies to many patients presenting in severe shock states, especially in septic shock. These patients are often tachypnic and apparently dyspneic due to the metabolic acidosis that they have, and sometimes this leads treating doctors to misdiagnose the need for intubation before addressing the shock state. And this unfortunately often results in them having to manage a post-intubation arrest just a few minutes later. So, am I really questioning the foundations of emergency medicine? No. Well, not really. You see, the ABCs are really a guide of priorities, which has an assessment intervention flow that is to be performed based on those priorities. Now, how this is done is highly dependent on availability of resources. Now, a single doctor ED team will surely do it differently from a large multidisciplinary team effort. Now, what should be abundantly clear is that when resources are available, assessment for C should never wait for completion of interventions for A and B. It is much better to think of it as ABC, a total set of goals to be achieved, instead of a distinctly separate process flow A, B, and C. Now, with this in mind, we can see that the goals to be achieved are A, an open and maintained airway, and B, an unhindered breathing with adequate oxygenation. As for C, the goals are twofold: to identify the presence of and the cause of shock, and two, any interventions to treat the reversible causes that we can identify, and if we cannot immediately treat the reversible causes, how do we reduce the impact of shock, and how do we resuscitate the patient until definitive treatment can be given and carried out. So therefore, in identifying shock, we have to think about it as these are the goals that we need to address in C. So here we can say that identifying shock is a very important first step. We know this. It is important to do it like a pro, not a noob. Anyone can diagnose shock in the collapse state, but a pro picks up shock at an early stage, either clinically, by signs of distal perfusion, venous contraction, sympathetic activation, and so on, or by using various monitors and or various blood investigations. Now, my teenage daughter tells me that nowadays being a pro is not good enough. You have to be a hacker. Now, the hacker predicts the likelihood of deterioration into a shock state. Obviously, that is so much better. And I look forward to seeing the hacker in all of you emerging. Now, once we have identified the presence of shock, it is essential now to proceed to ask the question, what are the causes of this shock? Traditionally, we are taught to consider the only 4 causes of shock, right? And we know what these are. As a young doctor, I was told, first, rule out cardiogenic shock, because that's the only one where you can't give fluids. Well, that's one way. You can also think of it based on syndromic presentation or based on frequency of cases. And in this situation, you will see very clearly that you may want to consider septic shock first, as because this is the most likely one to occur. But whichever method you wish to do in trying to figure out the causes of shock is really up to you. But I will say this, our better understanding of shock today tells us that in many patients, especially those that we commonly see with complicated and colorful medical history, they cannot be neatly grouped into only one of these 4 causes, and there are often very significant overlaps. As an example, in septic shock due to septic cardiomyopathy, they respond very poorly to fluids. Whereas on the other hand, sometimes patients with cardiogenic shock needs fluids to increase venous filling pressures. So it may be less useful to try to determine what types of shock are predominant, but rather try to answer 4 questions which will help us manage the patient appropriately and safely. And I think these are the 4 questions that we want to look at. Primarily, they are, what is the volume status of the patient? Is this patient euvolemic or hypovolemic? Are they fluid responsive? Whether are we expecting any increase, or can we get any increase in intravascular, with increase in improvement in cardiac output with any increase in intravascular volume? And what is their cardiac output? And is that sufficient to meet their needs? And lastly, but most importantly, what is the tissue perfusion overall? Is the perfusion adequate to maintain aerobic metabolism? Now, these are the 4 main questions, and I will run through with everybody how do we use these questions to guide our C management of patients. Now, assessment of volume status has been the holy grail of critical care medicine for many decades, spawning so many kinds of invasive monitoring that we know of today. Unfortunately, it's much more difficult measure than originally considered. Previously taught gold standards, example CVP, has become nearly obsolete after being proven quite types of shock are predominant, but rather try to answer 4 questions which will help us manage the patient appropriately and safely. And I think these are the 4 questions that we want to look at. Primarily, they are, what is the volume status of the patient? Is this patient euvolemic or hypovolemic? Are they fluid responsive? Whether are we expecting any increase, or can we get any increase in intravascular, with increase in improvement in cardiac output with any increase in intravascular volume? And what is their cardiac output? And is that sufficient to meet their needs? And lastly, but most importantly, what is the tissue perfusion overall? Is the perfusion adequate to maintain aerobic metabolism? Now, these are the 4 main questions, and I will run through with everybody how do we use these questions to guide our C management of patients. Now, assessment of volume status has been the holy grail of critical care medicine for many decades, spawning so many kinds of invasive monitoring that we know of today. Unfortunately, it's much more difficult measure than originally considered. Previously taught gold standards, example CVP, has become nearly obsolete after being proven quite inaccurate, whereas others have just been quite unreliable. Now, in the ED, clinical assessment is useful clinical assessment of volume status is useful at the onset, but not particularly useful as a continuing monitoring tool. Hemodynamics and blood gas results are often not reflective of the condition of the situation. Ultrasound tends to be susceptible to many variables, but luckily, and obviously invasive catheters are not particularly useful in the ED. But luckily, it appears that knowing the volume status of the patient is not nearly as important as knowing whether the patient will respond positively to a fluid bolus, right? So sometimes knowing the volume status may be kind of a whatever statement. It may be more important for us to look at what is the fluid responsiveness of the patient. Now, in terms of fluid responsiveness, this graph I feel illustrates it best, in that regardless of whether in your patient with the cardiac output that's normal or the cardiac output that's decreased, the patient may either be fluid responsive or not. Now, it is therefore time to get rid of the automatic myth that fluids will worsen cardiac dysfunction, and that's not always true. And we have to recognize that in many patients who have a decreased LV function, they may respond positively with some amount of fluid. It is also time to recognize fluids for what it really is, which is a high-risk medication. Now, especially in the context of a critically ill patient, giving too little fluids is bad, giving too much fluids is bad. Giving it early is often good, but giving it late can be bad. So giving fluids has a narrow therapeutic index and a very small therapeutic window, and that ultimately defines a high-risk medication. So assessing for fluid responsiveness in the ED, you are probably familiar with. But I've taken the liberty of ranking it based on ease of use and the cost needed. To me, the simplest way is to give small boluses of IV fluids, about 200 ml, which is really 1 cup of water, but to give it rapidly, and then to assess for response. The passive leg raise test essentially does the same thing by increasing venous returns from the lower limbs. You can get one of these more expensive non-invasive monitors, which will give you some validated results, and especially when we look at stroke volume variation and pulse pressure variation, which may indicate to us the presence of fluid responsiveness. Or in intubated patients, you could initiate a 15-second end expiratory occlusion test, which essentially does the same thing as the above. Now, it's important that if we have determined the patient to be fluid responsive, that means that you can give a fluid bolus safely, but it does not mean that you should automatically give a lot of fluids. Now, at this point, let us consider which fluid and when should we give it. Now, it is clear that in hemorrhage and hemorrhagic situations, the priority should be to stop the bleeding, replacing blood losses with blood products early, and therefore giving undetermined fluids per se may not be the best thing to do. As for the other conditions, in most other conditions, that we should resort to using isotonic balanced crystalloids. Now, okay, don't just reach for the normal saline. I said isotonic, I said balanced, and I said crystalloids. So normal saline isn't on the list because normal saline will result in hyperchloremic metabolic acidosis. Gelafundin isn't on the list as well. When giving fluids, we should give it early, we should give it in defined boluses, and definitely we should reassess the patient's condition in between. The days of running fast, free flow of fluids, and then coming back to realize just a short while later that 3 and 4 liters of fluids have gone in should be over. Patients need to be assessed after each defined bolus of fluids, and after at each time that we start fluids, we must have some kind of end target in mind, or some kind of end point in mind, right? So reassessment is as per normal as listed here, but it's really important to figure out what is the end point of fluid resuscitation. And we should never allow fluids to run without looking at a known endpoint. What is the cardiac output is our third question. The cardiac output is essentially a measure of how the pump is working and guides us this way, right? In the sense that if the pump is working poorly, we must attempt to correct the primary cardiac pathology, the primary cardiac pathophysiology. If the pump is adversely impacted by some reversible cause, we must correct that reversible cause. And if the pump is working fine, then definitely let's look somewhere else for the cause of the problem. We should recognize that knowing how the pump functions is merely a small view of the entire problem, for tissue perfusion doesn't depend primarily only on pump function. Here we can ask the question, vasopressors, when and where? Which and when? Now, vasopressors are often used to support circulatory and cardiac function, but they must be recognized as two-edged swords and definitely not to be used in all kinds of shock. Right? There is little use for them in hemorrhagic shock, and in fact for most other types of isolated hypovolemic shock. Right? But they are core and central to the management of sepsis, post-resus care, in some cardiogenic shock, with fluid responsiveness, and often in refractory shock states. If given, vasopressors should be given early, after volume resuscitation, and we should always look for opportunities to reduce the dose whenever we can. We have to recognize that in Malaysia, most vasopressors given in the ED is given via a peripheral line and not a central line. This is not the standard of care throughout the world. And therefore, if we are extrapolating use of vasopressor results from other countries that administer it through central lines, there may be defects in our understanding and our outcomes. Therefore, we have to understand that although giving vasopressors peripherally appear to be effective and rather safe, we must understand that occasionally we have to still check that after giving it, there is some effect to show that the vasopressors are indeed reaching the central circulation and not just concentrated at the peripheries where the line is. Ultimately, we should be aiming for maintaining circulatory pressures and improving perfusion simultaneously. The fourth question is what is the tissue perfusion? What is adequate perfusion? And whether we can maintain aerobic metabolism or not. Sometimes the most important part is the one that you cannot see and cannot measure. And this is tissue perfusion. After all, shock is about keeping cells and organs alive. Life, described in biochemical terms, is about using oxygen to burn glucose, both of which brought by the circulation into the cells in order for the cell to produce ATP, which powers the cell and keeps it alive. If this process collapses due to the loss of circulation or loss of inadequate oxygen or due to inadequate perfusion, then ultimately what happens is that the cell will start dying, right? So we have to understand that as long as the cells are alive, the organs will live and we live. And conversely, if enough cells die, we die. So therefore, knowing the extent of overall tissue perfusion is very important and is the key to survival. Markers of perfusion in the ED can be clinical, and especially we look more and more at the role of CRTs to identify distal perfusion, the good SpO2 waveform to identify distal perfusion as well. It could be investigative results, worsening of base deficit, or increasing lactate levels, or worsening of a HECMA metabolic acidosis, or some others interesting devices today, some of which measure tissue oxygen saturation levels using near-infrared spectrometry, some looking at the increased PCO2 gaps, either between venous and arterial, or tissue in sublingual and arterial, or those measured by capnography. There is a lot of research going on in this area, so definitely watch this space. So now we've covered the 4 questions that help our management of C. Let's say we have done those and the patient seems okay. What next? Now, remember the hacker, right? Now, these are the predictors of in-hospital mortality if you can identify them. And they are lactate levels at more than 6 millimole per liter. It's worse if the lactate is increasing or even not clearing off in time. The best deficit at more than 10 has a high risk of death within the next 7 days, and that's good evidence on this. And interestingly, hyperglycemia more than 10 millimole per liter is associated with all-cause mortality in hospital, and that's worse if the patient is not a pre-existing diabetic. So therefore, in summary, the take-home messages are as follows. Sometimes C comes first, but always don't delay assessment of for C. Number 2, look for signs of shock and do it like a pro. Don't be a noob. Consider the causes of shock. There are only 4, but better, there are only 4 questions that need answering, and those questions, once answered, will guide your management. Most importantly, predict, and if possible, watch out for deterioration and do it like a hacker. So, my dear colleagues, I hope if you consider that if you think that your practice is still the same after this lecture, then I would have failed. I hope you have take a moment to reconsider some of the suggestions I put here. Thank you very much. Take care.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning. Thank you for inviting me today to deliver a talk on early warning signs of illness. I don't have any conflict of interest in giving this talk today. My talk will include the definition, the purposes, the relevancy, and the types of EWS. And of course, most important is to touch a little bit on the evidence-based medicine on EWS. So the EWS stands for the early warning score. That was initially developed by the Royal College of Physicians in collaboration with the National Health Service in the United Kingdom to facilitate the early detection of deterioration in patient condition in any healthcare setting. Initially, it was produced for the utility in the pre-hospital care and also in the emergency department setting. But however, nowadays it is utilized throughout hospital care setting, including general wards and ICU. So why it was established? Basically, it is to improve the process of patient being observed and monitored. It is also utilized to make our communication more efficient within the multidisciplinary team with regards to changes in patient condition. It will ensure timely intervention given to patients who are worsening in their condition. And of course, it will assist the nursing and medical team to do a much better clinical decision making in a timely manner. And of course, it will provide information and education for the family and patient alike on their condition. And of course, overall, the use of EWS will enhance patient safety. So why so relevant in our setting in Malaysia? As you all know, in the acute care setting in Malaysia, especially in the emergency department, we are facing with the high burdens of patient attendance every day, regardless of days of the week, so that the use of EWS will guide us to focus on a patient or patients who need most in the monitoring based on their category of scoring. This is the anatomy, the diagram of how it works. It involves data taking, on patients by the healthcare providers, which include the vital signs, clinical examination, laboratory values, test values, and this will be gathered all together and recorded and documented in either manual or electronic record or as a scoring system, and the scoring system will guide us to take as necessary action, which is on this efferent limb. So these are the types of clinical warning scores that are commonly used. The first two, especially these are the two types that are commonly used in the United Kingdom and also in Kementerian Kesihatan Malaysia setting nowadays. I will touch a little bit on the mortality in ED sepsis, but I will not touch on the pediatric warning score or modified obstetric early warning score because of time's sake. This is a good example of the scoring system used when it was first established in 2012. It consists of 6 clinical parameters that is given points for each of the parameters ranging from 0 to 3. And those parameters scoring will be aggregated and given a coded value, which I will talk in the next few slides. But if the patient is receiving oxygen supplementation, then automatically the scoring aggregate will be added up to 2. So if the aggregate scoring range from 1 to 4, the patient is categorized as a low clinical risk. If the patient score is 5 and 6 or 5 or 6, then the patient is categorized as a medium clinical risk. But if the patient receiving or any 3 score of any of the parameters, automatically the patient will be categorized as high clinical risk. So if the patient has a score of 7 or more, similarly, the patient is categorized as high clinical risk. When I say clinical risk, the patient is at risk of high mortality and also high morbidity, and also a high probability for ICU admission later during the stay. So the low risk, basically how we interpret this clinically, for those patients with a low new score, basically the patient can be attended by registered clinical nurse, and the monitoring is not as frequent for those at high clinical risk. And for those with medium score, the patient can be monitored or observed by doctor, medical officers, or registrars. And high score, of course, this will alert the primary team to alert critical care team or specialist or consultant, and the patient needs to be monitored or observed more frequently. So this is the recommendation by the Royal College of Physicians. If the patient's new score is 4 or less, or low category, then this patient can be monitored 12 hourly or perhaps between 12 to 24 hourly. So if the score is between 5 and 6 or 5 and 6, then the score will tell us that the patient perhaps need a more frequent monitoring. What we suggested is within 4 hourly, and if the patient scores 7 or more, not only patient needs to be monitored aggressively by the nurses, but also need to be seen by a senior consultant or specialist with more frequent timely interval. So this is an example of the news scoring card, which was utilized or is utilized in the United Kingdom, either manually or electronically. It consists of all the parameters that need to be recorded, and also most important, the time need to be placed here, recorded as well, so that we can see the trending of the new scoring. So if the score keep increasing, that will alert the healthcare providers to take more attention on the patient care. 5 years after the establishment of the News 1, The Royal College of Physicians in the United Kingdom has introduced a news tool, the second version, which include the scoring on the use of oxygen and the pulse oximetry value. This news tool is specifically focusing on the patient with the hypercapnic state or COPD patient. And the recommendation for the news tool is that if the patient score 5 or more, that the healthcare providers should be aware or suspect that the patient is having sepsis. Originally, the news 2 is recommended only for patients more than 16 years of age or 16 or more. And as I said before, it is originally intended for the emergency and pre-hospital care setting, but nowadays it can be used throughout the hospital setting, including the general wards. This is the modified early warning score. The only difference is that it is basically excluded the use of the SpO2. It has only 5 parameters. It is a little bit easier, not to say much easier, but a little bit easier to do the scoring. So that this is an alternative to news 2, which has the same categories of risk, which is low, medium, and high. It is an example which I took from the MET calculator online. If you put in the scoring for the MUSE, for the modified early warning score, it will give rise to a statement of interpretation. For instance, for this case, the score is 6. It tells us that the patient is having 30% mortality probability at 60 days and a chance of ICU admission, and it will give you recommendation for higher level care. What is the evidence of EWS? Thank God, Health Technology Assessment Report, Ministry of Health has published this booklet on the National Early Warning Score. For your information, quite a number of KKM facility has utilized a news scoring system. This book basically tells the evidence base about the utility of EWS. So what it tells us, basically, it is a systematic review of thousands of papers on EWS, and they focus on the one that very pertinent and very robust evidence. It utilizes the ROC curve value. Just to recap a little bit what ROC curve means, it is a tool, called a scientific tool or the statistical tool that will tell us or distinguish between two diagnostic groups or modalities, whether it is good or bad in terms of its specificity and sensitivity. The value that we should consider is more than 0.7. So any value of ROC more than 0.7, it tells us that this tool intervention is good in distinguishing the particular disease or condition. So bear in mind with that value, for the general cases, what the evidence in the book says that it is quite good in predicting 24-hour mortality, especially for those with neurological, cardiovascular, and respiratory diseases generally. But it is not so good in distinguishing those or in predicting mortality for those with the GI cases. How about the evidence based on the use of news or MUSE in ED cases? Overall, news and MUSE is pretty good as a tool to predict combined outcome of death and ICU admission. Okay? You can see the news has a value of 0.71 in predicting the combination of outcome, whereas MUSE has a much better predictive tool for mortality in general, way above 0.8. How about the tool as a predictive tool for short-term mortality and long-term mortality? Again, News and Muse has proven as a good predictive tool for mortality within 24 hours, within 40 hours, and so on until 30 days. The value is well above 0.8. How about in sepsis? In sepsis, if you compare with the QSOFA and SIRS criteria, of course, the use of the News scoring system, Muse scoring system in the department, it has a very good area under the curve value of more than 0.75. Of course, in the ward, also in the general wards, it has a much better predictive value for mortality compared to QSOFA and SIRS. For pre-hospital care, again, the value for predicting mortality and morbidity is way above 0.8, especially for the 24-hour mortality and 30-day mortality. And for overall mortality, it's also above 0.8. How about in COVID cases is very interesting. Not so many evidence based on the predictive tool for mortality and morbidity in COVID-19 cases. However, there's one good publication done last year, published in the Scandinavian journal Trauma and Resuscitation Emergency Medicine, looking at the News score as a predictive tool for mortality among the COVID-19 cases. So what they have done, they compare again with QSOFA and CUP65, looking at the area under the curve for those scoring system, and as clearly it shows that the News 2, for the high score above 5 or even over 6, the area under the curve is well way above the 0.7 value, whereas for QSOFA and CUP score is less than 0.7. So it means that early studies has proven that the use of EWS or News scoring system is a good predictive tool for mortality among COVID-19 cases in emergency department and in general wards. How about the safety? People talk about the safety of this scoring system. Of course, any system, there's no 100% safety. There is an issue of serious adverse outcome from the utility of this News score. One of the worries is about the decreasing accuracy of News scoring system if the score is high. There's also worried issue about if the News scoring system is not done properly by the nursing staff or doctors, it can have a bad implication on patient outcome, especially increase in mortality. So that means if the nursing staff or the healthcare providers don't know to use a News score properly, this will result in increase in mortality trending and also morbidity. And the data has also proven that the use of a News score during the weekend may have some negative effect on, especially on the inadequate response to any scoring aggregate. And again, this directly or indirectly will result in higher mortality and morbidity. Again, this safety on the accuracy, you can see here that the higher the score, then the inadequate response probability is much higher compared to those group of patients with the lower score. Yeah, I mean, you look at that odds of getting inadequate response over the weekend is 4 times more. If you look at the odds of having inadequate response of lower score, is about 6 times. However, in higher score, it range from 40 to 177 more odds of getting inadequate response. So this could be worrying. However, overall evidence base has said that the use of early warning score system has a more benefit compared to the safety issue. So when it works well, of course, staff training is important before you commence the start of this scoring system. This flow chart shows what the KKM guys or our colleagues in KKM is doing. When you want to implement this early warning score, you must have a good training session and continuous quality improvement better to monitor the outcome of this system. Take home message, the use of news or national early warning score system is benefiting us. But evidence base is clearly proven that will improve patient safety culture. So with that, again, I would like to say thank you so much for inviting me today. Again, I hope that this talk will enlighten you on the subject of early warning score. Thank you so much.
Welcome. Thank you for joining me. I'm Felipe Tren, an emergency physician and researcher at the Division of Emergency Ultrasound and Center for Resuscitation Science at University of Pennsylvania. I'm also a member of the Resuscitative TE Project, which is a multidisciplinary initiative aimed to advance, disseminate knowledge, and promote excellence in the practice of resuscitative TE. In this presentation, I would like to give you a brief overview on the rationale and supporting evidence for the use of transesophageal echocardiography, or TEE, in cardiac arrest resuscitation. This is an example of a case of TEE doing intra-arrest resuscitation. This is a mid-esophageal 4-chamber view during ongoing CPR. You can see all 4 chambers here, the effect of CPR in progress. This means no time lost to quote-unquote develop the view when the time for a rhythm or a pulse check comes. And this idea is not actually new, not new at all, in fact. TEE has been used to study cardiac arrest hemodynamics since the early 1990s. Back then, it was actually cardiologists that were interested in TEE as a modality that helped them assess CPR physiology and specifically to evaluate the direction of blood flow. Interestingly, these and other studies are actually the foundation of our current understanding of how closed chest CPR works. And fast forward to now, we have learned a lot using transesophageal echocardiography in resuscitations during cardiac arrest. If you're interested in a comprehensive review of this topic, our group published this scoping review last year, which has a nice summary of the concepts and the evidence that we'll introduce to you today. So, summarizing the use of TEE in cardiac arrest, we can start by what is the most common application of echocardiography in general during cardiac arrest resuscitation, which is it's used to identify reversible pathology, those etiologies that could explain the patient's arrest. We can also use it to assess the effectiveness of the interventions that we do in real time during the resuscitation of that cardiac arrest patient. We can use it also to guide procedures, for instance, the cannulation for a VA ECMO in the case of ECPR or ECLS. And lastly, what I think is the most important and promising application is what makes TEE actually unique and distinctive when we compare it to TTE, and its ability to actually assess the quality and potentially optimize the quality of chest compressions. Starting with the example that I mentioned, using TEE to identify reversible causes, this is probably a self-explanatory case, right? You see, in this case, a large occlusive thrombus in the right atrium, an MTRV. Essentially, this is obstructive shock physiology. In this case, this patient had a PA arrest and had high-quality CPR during transport, epinephrine, and everything as directed by ACLS guidelines. However, this patient was never going to achieve ROSC unless we deviated from the ACLS pathway in order to treat that occlusive thrombus specifically. And that patient in that case received thrombolytics and later went for thrombectomy. Or a more common case of pericardial effusion, and specifically cardiac tamponade. It's an image of a patient with a large pericardial effusion identified in a bicaval window with TEE. And as I mentioned, we have the possibility not only to make the diagnosis, such as this case of a large intracardiac thrombus that I showed you before, but in that very same case, we actually had the possibility to assess in real time the effect of thrombolytics after TPA administration. So we saw in real time that clot being lysed throughout that resuscitation. Identification of RV failure or V dilation as a sign of RV failure that could lead us to think or to make the diagnosis of underlying massive pulmonary embolism is one of the other commonly cited pathologies that we need to look for, that we are expected to think about as part of that assessment of reversible causes, specifically in the case of PEA arrest. And fine ventricular fibrillation is one of the additional pathologies or entities that we have identified with the use of TE systematically, and that is the possibility to identify patients that have, like in this case, fine ventricular fibrillation that were otherwise thought to be actually in a systole, actually, and not in PEA. And so this is something that, like in this case, we can then proceed to immediately defibrillate with the probe in place and with that image of the heart in front of us and provide the patient the right treatment. And as I mentioned, cannulation for ECMO is one of the many procedures that we can guide during a resuscitation. This is a common procedure. We could say that is a growing field, the field of ECPR and extracorporeal support, and for selected indications, for instance, refractory VF. And if you have any experience with this patients, it is rather challenging to identify and specifically to differentiate between the femoral artery and the femoral vein. And so in order to reliably establish that we have cannulated the artery after accessing the femoral artery, we confirm with a descending thoracic aortic view that is very easy to obtain in TEE. And as depicted in this image, we can confirm reliably that indeed we have cannulated the artery and not the vein with that guide wire. On the venous side, we can actually, in this case, it's a bicaval view, we can visualize the venous guide wire in the right atrium, confirming the presence of our guide wire in the right place, and then over that wire advance the cannula. This has been described by a group of emergency physicians at University of Utah a few years ago, and I would say that represents the standard of care in many of our centers. I said reversible pathology will be one of the common applications, just like we do with transthoracic assessment of interventions and guidance of procedures. But I mentioned that what I believe we have the biggest potential for transesophageal echo and cardiac arrest is actually the improvement of CPR quality. One of the aspects by which we believe CPR can be improved is simply by shortening the process of CPR. There is already some evidence from a retrospective study conducted in the emergency department setting that show that when using TEE during resuscitations compared to TTE, there was a significantly shorter interruption of CPR pauses. But the concept that my team, along with others, have been working on for the past couple of years is the potential, the use specifically of TE to assess in real time the quality of the chest compressions, to visualize what is happening with the heart while we are doing closed chest CPR. And to put this into context, we know that chest compressions are a fundamental component in the cardiopulmonary resuscitation CPR chain of survival. One of the most important conclusions drawn after decades of extensive research in cardiac arrest is that high-quality chest compressions is the single most important and most significant factor to improve outcomes in cardiac arrest resuscitation. Compressions should be started as early as possible and should be done hard and fast, as we often say, and should be to minimize as much as possible the interruptions. And the reality is that since 1960s, when closed chest CPR was first described, until now, really not much has changed. So at least 60 years, we haven't really evolved much in the way we do closed chest CPR in resuscitation. So back in 1960, according to the original description, it was the direct compression of the LV between the sternum and the spine that creates the pressure gradient between the ventricle and the ascending aorta. So the venous valves and the atrioventricular valves should explain why the blood is ejected forward into the ascending aorta. So this model has been known since then as the cardiac pump theory and is the predominant, or what we think is a predominant model to explain the effectiveness of closed chest CPR in resuscitation. Now, regarding the way we do CPR, the exact location of the hands during CPR has changed over the years. For many years, the resuscitation guidelines recommended the use of the internipple line as the anatomical landmark to position the hands. However, the 2010 guidelines concluded that the internipple line was actually not a reliable landmark for hand placement. This was actually based on several studies of CT scans and simulation in real patients, which had shown that the structures that are located immediately underneath the sternum at this point are not exactly the ones that we intend to compress. One of the studies was the one by Shin, a Korean group that in 2007 looked at chest CTs performed in 189 patients and looked at the structures that were located underneath this internipple line. In this study, they demonstrated that about 80% of patients, the intrathoracic structures located just underneath the internipple line was the ascending aorta in 18%, the root of the aorta in 48%, and the left ventricular outflow tract in 12%, rather than the left ventricle itself, which was only found in 20% of the patients. NISTAS published more recently a similar study basically confirming these findings with MRI. And I know you might be wondering at this point, well, is there any clinical evidence to back this up? So far, we have just seen CT studies, radiology studies. And the answer is, indeed, there is actually pretty good evidence. An observational prospective study was published in 2009, over 10 years ago. This study, also from a Korean group, performed TE in 34 patients with non-traumatic cardiac arrest. The area of maximal compression in this case was found to be located at the ascending aorta in 59% of the cases, like shown in these pictures. In 41% of the patients, it was located over the left ventricular outflow tract. This is the initial area of maximal compression when assessed with TE in patients with out-of-hospital cardiac arrest. So if you agree that the left ventricle stroke volume is why we are doing CPR, then this kind of makes a huge difference. In fact, as this image shows here, the same study showed a relationship between the left ventricular stroke volume and the location of the area of maximal compression. The LV stroke volume is on the left, and the location of the AMC measured centimeters from the aortic valve is at the bottom. Negative numbers mean that the area of maximal compression is on the LV side of the aortic valve. This linear regression essentially shows that the left ventricle stroke volume is indeed higher when the area of maximal compression is found at the ventricular side rather than distal to the aortic valve. This is an example side by side of images of the same patient before and after having repositioned that position of the hands, the area of maximal compression. And as I showed you, the implication of this anatomic variation that we know exists across patients in the cardiac structures that are located underneath the sternum is that only sometimes we're actually obstructing the outflow tract. But in some cases, we're actually simply not compressing the left ventricle. And this is also a problem, as you might expect. This is a recent example from our emergency department. You see that I recorded the entitled CO2 value that at that point was 11. And you see that while we have CPR on progress with a mechanical device in that case, there is minimal shortening of the diameter of that left ventricle, so minimal compressions. This is the same patient having switched then to manual CPR and having optimized the location of the hands to obtain a more meaningful compression of that left ventricle without obstructing the left ventricular outflow tract. You see that roughly a minute and a half into that change, the entitled CO2 has improved, and that only continued to improve. The subsequent check was 28. This is a waveform capnography, inline capnography during the resuscitation. The entitled CO2 eventually reached 32, which is fairly good, and we know based on lots of physiology studies that that is the best predictor of that patient gaining ROSC. And indeed, in that very same case, during the next rhythm check, that after having those entitled CO2 values, the patient actually achieved ROSC. This is a example side by side of that same patient. On the left, the initial image without compression of that LV, and on the right side is the last image after repositioning and switching to manual CPR. And if that doesn't convince you, this is an image of another patient of a similar case where we have advanced the TE probe to see the left ventricle in a transgastric view. We see that the LV is actually not being compressed at all during the chest compressions. How often do we see this problem in real practice? According to data from our center, compression of the left ventricular outflow tract or the aortic root was found to be the case in 53% of the patients that we assess with TEE. And there is a related study by an Italian group that now actually went a step forward and correlated the presence of LVOT opening during the compression phase of CPR in survival in cardiac arrest patients. This is a small retrospective study, only 19 patients. They were looking at primary outcome of 24-hour survival, but this is the first study linking LVOT compression in survival in cardiac arrest patients. So with that, we have a number of studies also that had previously documented, sort of provided the proof of concept in animals that this is actually mechanistically correct, that when we compress the left ventricle in animals, in pigs in this case, in a study by Kent and Anderson, we obtain higher coronary perfusion pressures, and that only by compressing at the left ventricle and not at the left ventricular outflow tract or the aortic root, we can obtain ROSC. And that is just stunning data from those preclinical studies that, again, provide the foundation for the clinical studies that we are conducting right now. So in summary, TE can help us identify the patient's specific hemodynamics during CPR. It can help us identify reversible pathology. It can help us optimize the quality of the chest compressions. To take home, intra-arrest TE is feasible and is safe. It's clinically influential, as demonstrated in a number of studies in the emergency and critical care setting. And specifically in the population of cardiac arrest patients, it allows us to characterize the cardiac activity, to determine the presence of reversible pathology, and to optimize the quality of CPR. If you're interested in learning more about resuscitative TE, you can find lots of educational resources, including this lecture and many others in the project's website, resuscitativeTE.com. That is my Twitter handle, and that is my email. Feel free to reach out with questions, and I thank you for your attention.
Thank you, Mr. Chairman, for the kind introduction. Assalamualaikum and very good morning to all. I'm Dr. Roslanuddin Saruddin from Hospital Sultan Al Bahiyah Al Usta. I'm very honored to be here to present persistent metabolic acidosis, my 10-step approach. My outline of presentation is actually, first of all, it's just an introduction for metabolic acidosis, what it is and what we should worry about, whether it can affect your patient in front of you, especially the critical patient in the emergency department. And after that, we'll see whether with that, we'll look into it and see whether what we can do about it and how we can analyze it. But it's not really difficult. It's just more practical in emergency department setting. So there will not be anything about urinary iron gap or like something like osmolar gap. Just a day-to-day practice. And then in terms of the analysis, we will look into the high anion gap metabolic acidosis and normal anion gap metabolic acidosis. Then we will look into the delta gap or delta ratio and a little bit of clinical application, whether we should treat non-anion gap metabolic acidosis or high anion gap metabolic acidosis with a little bit of evidence. Okay, so what is metabolic acidosis? As you know, it's distribution. It's a acid-base disturbance where there is a deficiency in bases, or in this case, is bicarbonate. Whether it's actually a consumption of bicarbonate, loss of bicarbonate, or it's actually conversion of bicarbonate in the body. So should we be concerned about it? The short answer is yes. Although all the evidence is actually, a lot of the evidence is from the animal studies, but there is increasing amount of recent data that says that it's actually have a patient-centered outcome, affect our patient. So most of it is actually on the respiratory and cardiovascular system. Increase in respiratory drive, which we know is not good. We just increase the PCL, have arterial vasodilation where you can limit sepsis and reduce the cardiac inotropism and eventually cardiac output and also arrhythmia. So, like I said, a lot of the evidence is from the animal studies, but recently published by CAR-ICU, which is a landmark trial of this topic. Just a conclusion from the study. The patient, a cohort in the BiCARB group has less renal replacement therapy and compared to the control group. Another study, which is a SODA big study by Tom Kofuji, recently published in Neccs Track A in February. This is basically observation study of practice of ICUs in Asia and Australasia, mainly Australia and New Zealand. Basically, what they did is they just studied the pattern of usage of bicarbonate in patient with ICU. So they found out it's a lot of variation in the practice in terms of dose, in terms of the solution, in terms of the how fast to start the bicarb. And they also found out it's early bicarb is associated with less ICU mortality and higher BP at initial 6 hours of presentation. If you look into the CKD studies, the chronic kidney disease, there is a recent studies, RCTs in fact, prove that in CKD, even if you give bicarb at outpatient setting to improve the metabolic acidosis, they can improve the renal muscle mass and heart progression. Again, this is a little bit detail about bicarb ICU trial. This is published in 2018. This from the 26 ICUs in France, with almost 400 patients, 2 groups. It's a pragmatic RCTs, unblinded, with the cohort of patients with severe critical illness with SOFA score more than 4 and severe acidemia, where is the severe acidemia defined as pH less than 7.2 and bicarb less than 20. So what they did is they did a one-to-one randomization between the 2 groups, no bicarb and with a bicarb. But the bicarb solution that they give is actually 4.2% bicarb. It's not a pure bicarb. What they did is they doubled the volume to get the 4.2% bicarb, and they can give up 125 ml to 250 ml of 4.2% bicarb over 30 to 1 hour. And then they will do the APG and they see whether pH achieve more than 7.2. Not achieve 7.3, they can improve it. up to the maximum level of 1 gram. So they have two groups, and the outcome of the study from 389 patients, the primary composite outcome, which in terms of mortality and plus one organ failure, there's no difference, although there's 5% difference, but there's not significant, most probably due to lack of sample size, because most probably they overestimate the sample size calculation from correlational studies. And RRTs, another outcome, if you look at just RRTs, therapy, there is a significant difference of 17% with a significant value or NMT 6. And if you go further, you divide into a further subgroup of critical patient in ICU with AKIN more than 2, kidney failure group more than 2, the outcome is more pronounced in terms of composite outcome and also in terms of mortality. So I hope that this few evidence convince you all that we need to do something about metabolic services. Right? So my focus of presentation will be focused on the guideline, recent guideline published in 2019 from the French team. It's basically from the emergency physician and from the intensivists in France. Well, they did a consensus, and the last consensus in 1990, about 20 years ago. So we know that it's actually very difficult to do the guideline on metabolic acidosis because the evidence is not really a lot. So that's why we need 20 years to do another guideline like this. And then they did the brainstorming and they come up with 29 consensus, but half of it, 15 of it is just is an expert opinion. Okay, so we'll see. Okay. For the revision for step-by-step approach when you have patient with metabolic acidosis, the step 1, you need to diagnose metabolic acidosis first. Make sure it's a metabolic acidosis. How you do it? You look at the pH, look at the PCO2, bicarb, and pH deficit. And after that, after you diagnose metabolic acidosis, you need to calculate the expected PCO2 by Winter's formula. This is to ensure that you determine whether there is concurrent abnormalities as concurrent respiratory acidosis or concurrent respiratory alkalosis. There is a clinical implication in that. And step 3, after that, you calculate the anion gap. After you get all the electrolytes, you calculate the anion gaps. This is to see further delineate your metabolic acidosis into high anion gap metabolic acidosis and normal anion gap metabolic acidosis. And according to this guideline, you should add albumin correction. We'll go further later. And okay, if after your calculation of anion gap, the patient has high anion gap metabolic acidosis, you should calculate delta gap or delta ratio to diagnose whether on top of the high anion gap metabolic acidosis you have a concurrent NAGMA, because this also has a clinical implication. Okay, we'll go one by one. Okay, after you diagnose metabolic acidosis, we go to step 2. This is where you calculate expected PCO2 by this formula. So how you do it? 1.5 times expression by cup plus 8. The result is plus minus 2. Make sure it's compared with your ABGs of the patient. And let's say your expected PCO2, your patient ABG PCO2 is a lot more than your expected PCO2, your calculation, then the patient has concurrent respiratory acidosis. For example, with dengue patient with primary obstructive lung disease, like dengue patient, and on top of that, you have a bronchospasm or patient with asthma. And let's say the patient have a little less PCO2 compared to expected, then patient have concurrent respiratory alkalosis. For example, patient with dengue with metabolic acidosis, and now patient is hypoventilated, then which is, it's not good. And after you calculate the expected PCO2s, then you hopefully can get back your electrolytes, and then you calculate your electrolytes. Now you can calculate anion gap or corrected anion gap. Corrected anion gap means you add albumin correction. So the normal value is 12 plus minus 4. If you add potassium to it, The normal value is plus minus 4. And should you have albumin correction? Yes. From the guidelines say yes, great strong albumin. Why? Because as you know, anion gap, normally anion gap is physiological anion gap consists of phosphate and albumin. So basically, and you know that our critical illness patient, most of the time they have low albumin, especially in nature. They have low albumin, um, low albumin critical illness most likely due to a lot of things like hepatopathy, critical illness itself, loss of albumin in urine, or liver failure sometimes. And so basically, when you have low albumin, if you don't correct for it, so you will overestimate your anion gap, and you see anion gap is normal, which is actually not. So basically, because you know that albumin is part of a normal physiological anion gap, so you need to account for it. So basically, how you calculate it? Correct the anion gap plus albumin correction, which is normal albumin you take 40 minus your patient albumin times 0.25. Again, this is just a revision. What is anion gap? What is HACMA? What is NACMA? Okay. Okay. Like I said just now, I explained it. And why bother? Why you want to differentiate normal anion gap metabolite or high anion gap? First of all, from this you can get the etiology. HACMA at medical school we learn all this mnemonic. HACMA, cat mud pulse, and NACMA is used carb. So basically, one can help you achieve the diagnosis. Number two, because the recent evidence shows that NACMA you need to treat. HACMA basically a little bit difficult, uremic, maybe bicarbonate infusion, lactate, maybe DKA, not really sure. So if you get a HACMA and then you get metabolite cirrhosis, you need to calculate delta gap or delta ratio to diagnose concurrent NACMA, because I say just now NACMA you need to treat. We have a lot of evidence for it. So how you in this instance, I just show you the example of delta gap, which is a change in anion gap, which is anion gap minus normal anion gap, which is 12. So anion gap minus 12 minus the change in bicarbonate, which is normal bicarbonate is 24, minus the actual patient bicarb. So basically from this you get the result. The result from -6 to 6, which is normal. Okay. If it's less than -6, you have a mixed high anion gap metabolite and non-anion gap metabolite. So you have on top of the HACMA, you have a NACMA. This is, for example, clinically you have DKA, ketoacidosis, you have high anion gap metabolite, and you give a lot of liters and liters of sodium chloride infusion. After some time, you will get NACMA on top. So basically, you need to determine you have a NACMA because you need to treat the NACMA. If you're normal in -6 to 6, you have pure HACMA, and more than 6, you have HACMA plus metabolic alkalosis. Metabolic alkalosis is another topic altogether. Touch it. Okay. Another methods to use introduced by this guy, it's a little bit simpler even. So modified delta gap. If you check, if you arrange this into equation, you will get this. Eventually, you'll get the sodium minus chloride minus 36. So it's, you can use it. It's simpler. Okay. For evidence, what's the evidence that we should treat NACMA? There's actually a lot of evidence since 20 years ago until now, but I just highlight I highlight a few of the studies. Studies from Prof. Bunos, before and after study. This is the first study to show that balanced crystalloid is actually good and prevent kidney injury. And the split study by Paul Young, RCTs, the first RCT of this topic, it proved that this is RCTs compared with normal saline and plasma-like, no difference. However, there's a lot of limitation of this study. So basically, but this study shows that if you give normal saline less than 2 liters, it's actually quite safe. And this is the landmark trial of this topic, Salter ED and SMART trial, published in 2018. It's very big, 15,000 and 14,000 patients, comparing normal saline and balanced solution, including the reverse lactate. And it shows that use a balance solution to keep injury and also in fact prevent death, composite death. So, and if you go deeper into the balance, into the SMART trial, just a secondary analysis, a subgroup analysis of the SMART trial, just took this sepsis patient, and you will find that the result will be even more pronounced. Even more than 30 days mortality, 0.74, or actually 20 mortality, and all the other parameters, all the other secondary outcome also shows improvement in patient that you give a balanced solution. Okay, now I hope that you agree with me, you all agree with me that we should treat now. Now, should we treat high anion gap metabolic acidosis? This one is quite difficult. Currently, yeah, no, because this cohort is actually excluded by BACA ICU study. Uremia, yes, because this is actually by BACA ICU study. Lactic acidosis, yes, because again in BACA ICU study, pregnancy trial, they just in BACA ICU study they just exclude DKA, metabolic acidosis caused by toxicology causes, and also when you have persistent diarrhea. Persistent diarrhea is a non-anion gap metabolic acidosis. So because they assume that normal anion gap metabolic acidosis is the standard of care that you need to treat the backup, so they exclude it. Okay, so how about DKA? So very scarce evidence for DKA, whether you should treat actively backup. So we only have old system review 2011, mature HR panel intensive care. From here, the systemic review have 44 articles, and most of them is actually from the observation study, which is very small and very poor observation studies. Only 3 have a small RCT but different heterogeneity, timing, outcome, physical, threshold, and age. And from here, the conclusion is there is a slight transient improvement in metabolic acidosis in 2 of the RCTs, although small. But this RCT is using isotonic bicarb, and there is no improvement in glycemic control, and there is associated cerebral edema in pediatric cases. Be careful in pediatric. And there's from the 44 article, there's no study of severe acidosis, severe less than 6.5. And like I say, BICA ICU exclusion. You cannot make a conclusion with BICA ICU. So the study of BICA ICU, this is the result. I just want to show you the hazard ratio. You can see the good separation from the beginning, even from day 1. They have a good saturation and maintain until of a number of renal replacement therapies. Okay, again, another result that is very interesting by ICU. That as you know that BICA ICU patient in BICAP group there is less of RRT. If you go even deeper, why the BICAP group has less RRT, you can see that in BICAP group there is significantly less urine output, significantly less hyperkalemia, and significantly less acidemia. You can see this from box plot. You can see at 4 hours and 12 hours you have significantly less potassium compared to control group. So take home message. Yeah, a little bit of steward-based approach. Generally, steward-based approach compared to Henderson-Hasselbalch doesn't matter as long as you calculate anion and delta gap, because you will lead to the same conclusion. The Winter's formula, you should need to do it because you need to investigate the degree of compensation. You need to calculate anion gap, and you need to add albumin correction. You need to calculate delta gap to identify concurrent NAGMA, because if you have concurrent NAGMA, you need to treat it because it matters. You need to give backup because there's a lot of evidence. I think now we have enough evidence to say that we need to treat backup. And from the landmark backup ICU trial, exclusion criteria, uremic, HAGMA, lactic acidosis, and you should give backup. And for the DKA, still we're not sure yet, but the evidence against it is actually big. That, thank you. Any questions you can ask me during the session, or thank you very much.
Okay, very good morning, and thank you very much to Nexus for inviting me to give a talk on a topic that I think is very important to everybody to understand and know. Sometimes we do forget that post-resuscitative care is something that we should not oversee when we resuscitate a patient. Of course, when trying to resuscitate a patient, it does take out our energy and the time, and whether we are successful or not, it is actually tiring. But if we are successful most of the time, some of us tend to forget that post-resuscitative care is an intricate part of managing a patient in a critical setting. So in this topic, basically, the topic that was given is post-resuscitative care 10 steps. The reason why we're doing steps now to help to remind us as healthcare providers that to help us guide us to manage these patients post-resuscitatively, especially when you have attained return of cardiac circulation. Alright, so that's very important. So if you look at post-resuscitative care, so this is something that we should always remember when you successfully resuscitate a patient, a post-cardiac arrest syndrome. So this is something that basically you need to look at, take a step back and take a look at the patient and remind yourselves that these are the few things that we should be thinking of post-resuscitatively in a patient that has returned to spontaneous circulation. One of the things is that basically you're talking about anoxic brain injury. Anoxic brain injury, basically damage due to sometimes long period of hypoxia that may be something that can be detrimental for the care of the patient. Alright, so it basically determines outcome of patient. Alright. The other thing is that we have to think about the persistent precipitating pathology, and this could be the cause of the collapse, and we need to find out what actually caused the patient to actually deteriorate and collapse in front of us, or prior to this, prior to our resuscitation. Is there any arrested related myocardial dysfunction related to the collapse? So this is something that we also need to think about after we have managed successfully resuscitating a patient. And of course, in any pathophysiology of shock and collapse, there is always an occurrence of systemic ischemia and a reperfusion response due to the diversion of blood to main organs. So that's why it's important for us to think about all these issues as a syndrome called post-cardiac arrest syndrome. So what are the 10 steps to help you, guide you to manage a patient after successfully achieving ROSC? Right. So the first step, the few steps that you are looking at is basically airway, breathing, and circulation. Clear cut. This something is what you call this something a gut response that we actually do every day in our daily activities when resuscitating a patient. So don't forget that basically managing an airway is very important. So ensuring a patent airway, an open airway, and this is something that you need to reassess whether you actually during your resuscitation have not intubated a patient or provided definitive airway management. You must reassess the airway. This is very important. The other thing is that ensure spontaneous breathing on the patient. Do you need to help the patient to breathe to ensure that adequately oxygen is administered to the patient as what we predicted. And the last but not least, make sure that there is a good blood circulation to avoid shock in further damaging the patient as a vital step in our care and the initial step of post-resuscitation care. So again, this is something that under AHA 2020 ataupun the American Heart Association 2020, algorithms have been done to ensure that this all happens. So again, to remind you, basically once you need to decide whether this patient under airway does have a patent airway. If the patient has a patent airway, there is actually no need to actually intubate the patient. Intubating a patient is something of a challenge and has to be decided whether this act will actually do more harm rather than good for a patient later on if a successful ROSC is achieved. So this is something that you need to also think about when you manage the airway. So sometimes what happens is that after attaining ROSC, part of ROSC is not basically mainly for intubating. So if you need to look at whether or not the airway is patent, decision must be made here whether or not you need to protect the airway in terms of definitive airway management. The second thing that you have to think about is basically the respiratory parameters. So if you look at here, they have actually advised that if the breathing is good, within 10 to 12 breaths per minute, it looks like that patient has a normal breathing rate, which is acceptable and should be at that point of time acceptable for managing this patient. Now, again, SpO2 around 92% to 98% is acceptable, and the PaCO2 of 35 to 45 millimeter mercury is something that basically is a recommended parameter to fall back to. So again, you're talking about SpO2 of 100%. You might not achieve 100%, but it is recommended by AHA and also the European Resuscitation Council that basically you should start off with 100% oxygen giving to a patient until you are able to achieve or to assess the adequate parameters through an atrial blood gas to then start titrating the oxygen. This is something that is important because the issue of hypoxemia may worsen brain injury, and the issue of hyperoxemia, excessive oxygen, may increase oxidative stress to the cells and end up causing organ damage after reperfusion. So again, another thing that within circulation in the A, B, C, the first one, step 1, 2, and 3 that you must look into also is to manage the hemodynamic parameters. They have advised and recommended that a systolic blood pressure of more than 90 millimeter mercury is acceptable at this point of time, and the mean arterial pressure of more 65 millimeter mercury is our aim to ensure that the patient that gets the best possible treatment or recovery possible to near normal from prior before they collapse. So this is very important. So if you look at AHA 2020 guidelines, the initial stabilization phase that they have recommended here is a good guide for you to start off your post-resuscitation care. This is the European Resuscitation Council recommendation. Is a repetitive of AHA. Under the ILCOR 2020 guidelines, both European and American societies have agreed on the standard approach for the initial airway breathing circulation management of a patient that has achieved ROSC due to your resuscitation. All right. So now this step 4. This is something that has been mooted and spoken about. The ECG and cardiac intervention consideration. Now, if you're in the emergency department, you will realize that when a patient collapses, we tend to automatically ventilate the patient, whether intubating the patient or not. We ensure the ABCs are within normal limits with whatever knowledge that we have. But the other thing that the guidelines have recommended as a step 4 for your care is basically obtaining a 12-lead ECG, which we do. But again, the question is, there is a proposal that basically if the ECG, if you look at the European Society, if the ECG shows elevation, they have actually recommended a coronary angiogram or plus minus a PCI. And if there is the ECG is there's no ST elevation, they have actually considered CT brain and CTPA to look at the causes of the cardiac arrest. So this is something that we don't do, but now it is a recommendation whereby as a step 4, they have recommended that obtaining an ECG to look at cardiac causes is something that is suggested to be done for any patient. And it is something that may not be applicable in Malaysia because our constraints, but it is now a recommendation for LCOR 2020 or under the guidelines, new guidelines of resuscitation in 2020. All right. Now, step 5, determining the severity of anoxia. This is something that also we do by making sure our ABCs are within optimal recommended parameters. This is something that we try to avoid. The severity of anoxia being worsened and causing detrimental effects later on a patient that we have resuscitated. So again, HA has shown some sort of guidelines or algorithm to help you to do this. If a patient is alert and conscious, if the patient follows commands, therefore, then you can actually be safe and say that the period of anoxia during the time of resuscitation does not do much damage to the patient. But the problem is if the patient is comatose post-resuscitation, and the question is whether and we are unable to assess whether the patient can follow commands. So certain tests and assessment have been recommended, like targeted temperature management of the patient, a CT brain, EEG, and other critical care management has been proposed in view of looking at the severity of anoxia for the patient within this category of patients. So that's step 5 for you. And the question now is step 6. Go back to steps 5 and then you end up with step 6. Now, if the patient is mildly awake ataupun mildly comatose or semi-conscious, sorry that word, the wrong word I used. So the idea is that again, it is proposed that you need to ensure that the temperature is normal or within a core temperature, planned TTM management, maintain normoxia, normocapnia, and basically euglycemia. All right. So again, if patient is mildly semi-conscious or awake, it is easier for you to monitor the patient and assess the patient accordingly. But the challenge is when patient is severe or comatose within step 7 of the recommendation, whereby again it is recommended that you propose a targeted temperature control at the initial phase of resuscitation. Ensure that you maintain normoxia or normocapnia, euglycemia, and basically this is where the idea of a protective lung ventilation is in place if the patient ends up being intubated in a comatose state. That's very important. So if you look at AHA guidelines and European Council guidelines, they have the same thing. So they said temperature control within 32 to 36 degrees Celsius for more than 24 hours, prevent fever for at least 72 hours, maintain normoxia and normocapnia, protective ventilation, lung protective ventilation is recommended with a low tidal volume, which is currently in a practice. Avoid hypotension, an echocardiogram, and all what is stated here. And most of this is not done in emergency department, but now you must realize that basically this is something that we may have to do and consider doing in the emergency setting, especially when now we see that the duration of stay of a patient in critical condition post-resuscitative is a bit longer in the emergency department. So starting off treatment, maintaining stability of the patient is important for the continuum of care of the patient when the patient ends up in ICU. All right. So, targeted temperature management. This is something that has been mooted many years ago. Nothing new. Again, the recommendation is there, and basically the most important thing to understand is basically how it is being done. So they have recommended within 0 to 4 hours of time post resuscitation. So the induction phase should be there by rapid cooling, shivering management, etc. etc. So the induction phase should be within the 0 to 4 hours of arrival of patient in the department after attaining ROSC. Then basically within 4 to 28 hours duration, a maintenance phase that basically allows the patient to rest with adequate sedation and analgesia, monitoring potassium, glucose levels and other electrolytes to ensure normality of the blood results or electrolytes and other parameters that is important. Now, within 28 hours, recommendation is to rewarm the patient. And most important thing is after 36 hours to ensure that actually patient has achieved a parameter that basically ensures that there is no fever for the patient and ensure nomothermia, make sure that vital signs are all within the normal parameter to help to improve the outcome of the patient after 36 hours of ROSC. Now, again, there is a strong recommendation that the constant temperature is between 32 to 36 degrees Celsius, TTM for 24 hours after target temperature is achieved, and actively prevent fever, especially in comatose patient. And this is all level B recommendation. All studies that were presented during ILCOR and also reported does show that it is important for especially comatose patients to have a targeted temperature management in the initial phase post-resuscitation to ensure a better outcome or to give at least a chance for the patient to recover within the 36-hour period post-resuscitation. Alright, so again, this is just a graph to show you basically a table to show you the aim, duration, causation and the general care of patients post-resuscitation. So these are just protocols to follow. Some are done and practiced strictly within the facilities, but sometimes you can't afford to do it, and basically recommendations are there as a guide, and it all depends on us to how do we start off management and whether or not we should look at temperature as a goal to manage patients to give them a better chance of survival. All right, now step 8 that we should remind ourselves when we manage a patient post-resuscitation is to evaluate and treat reversible causes. So the reversible causes that basically are there again is the 5H and 5Ts, and I'm pretty sure that we are usually on this and managing this. Again, indirectly we are preventing hypovolemia, we will actually avoid hypoxia, we will actually try to control and avoid acidosis, and also hypo or hyperkalemia. The hypothermia phase basically again should be controlled with a targeted temperature management care, and the rest basically are part and parcel of what actually we do and try to do every time we resuscitate patient. So nothing new there in step 8. Now, this is something that is, I don't think we will be doing it in emergency department, but step 9 has proposed EEG to see the brain response post-resuscitation. This is something that has been occurring and being done in the ICU setting, and I'm pretty sure that, not sure whether it is something that needs to be done in our emergency setting. Most of the time, whether how long period it takes, most of the patients do end up in ICU, but within the guidelines is recommended that an EEG is done for a patient to look at the brain activity of a patient that we are resuscitating. This actually will help to prognosticate the outcome of the patient and will help us to decide whether post-resuscitative care that we want to do or what we want to do for the patient should be taken to the next level. If the brain ECG does not show any activity, therefore most likely the outcome will be not good. So that's very important. Okay, so again, within the EEG, they have actually recommended to do an EEG again to control seizures as one of the reasons of doing an early EEG. And the other thing is so that you can plan out anticonvulsant regimes for patients that probably will lead to seizures because of the ischemic brain that has occurred during the time of resuscitation or pre-resuscitation. And again, the recommendation of some certain medication within the European Council of Sodium Valproate and levetiracetam, basically it's something that is only recommendation. It's not a must. Alright, so that's very important. So one of the reasons why EEG is done to look at the prognosis and also to see whether we can actually identify early complication of seizures and control them during the phase of post-resuscitative care. Alright, so why do we need to detect seizure in post-resuscitative care? So again, this is something that is already been mentioned. There is no non-conclusive status epilepsy. There is no non-conclusive status epilepticus may be reasons that patients are not awakened from coma. So that is where they have actually commented. Now, prolonged epileptiform discharges are associated with secondary brain injury. So the question of detecting seizure earlier, post-resuscitation, is to ensure that basically we can prevent secondary brain injury due to seizures that might not be seen or evident clinically within the patient. All right. Now, predictor of poor outcome, again, the idea of basically predicting an outcome of the patient with or without targeted temperature management is something also important to look at the EEG pattern as mentioned before. All right. Now, this is something new, not that new actually, but when reading about ILCOR and the AHA guidelines, neuroprognostication of a patient is something that is important and mentioned quite extensively to look at outcome of the patient. Now, maybe this is because of the fact that it is important that we do not ventilate or manage a patient in ICU for a longer period of time, and it does help us to make a decision based on certain guidelines to either end or stop management of a patient. All right. So the general guideline is that basically there's no single predictor of 100%, which is 100% accurate. It must be a multi-model approach. Now, assessment should not be done when there is sedation, muscle relaxation, or other drugs that might affect the patient, right? So the question is when to perform the neuroprognostication. So recommendation is that with TTM more than 72 hours or more after rewarming the patient, or without TTM, the recommendation is within 72 hours. All right, so that's very important. So again, these are a few diagrams to look at the various types of modalities to use to make prognosis of a patient. Number one is to study the EEG. The second thing is biomarkers and certain imaging, CT scan and MRI, and clinical examination as what is basically recommended and being carried out at this point of time. So not a single modality, single predictor, but actually a multi-modal approach to determine the prognosis of a patient. All right. So this is something that was showed, neuroprognostication program, a diagram, sorry. So the idea is that if you have not planned a TTM, therefore it should be done within 72 hours with the recommendation of HCT and followed by MRI and other modes. So they have actually given you a guideline on what are the investigations that should be done within a patient within 72 hours. So this is just a diagram for us to learn and understand that these are the steps taken in ICU to prognosticate a patient's care after 72 hours of management. Okay, again, this is also the algorithm or guides that have been given to decide whether patient should be stopped or continued in their management. And again, these are basically ready available within AHA and ILCOR. It might be something that we are doing at this point of time, but again, it is something that we should actually take a look at and be knowledgeable about in case that we do have patients that stay more than 72 hours within our facility in the emergency department. All right. So these are the algorithms that have been again shown as a whole on how to manage patient post-resuscitatively. So all the 10 steps that you have shown, see, are within the AHA 2020 algorithm, also within the European Council 2021 algorithm, whereby all the 10 steps are mentioned and basically should be done simultaneously, concurrently, and if possible, that's very important. Okay, so all this that we do is actually for one reason only, to prevent a secondary occurrence. That's very important, and to ensure that we, after resuscitating patient, have the intention to ensure that patient can be rehabilitated and be able to be sent home well prior to the incident. This is something that has to start from us when we resuscitate the patient, has to be started from us for the initial steps of post-resuscitation care before our colleagues take up the care within in the ICU setting, and again a continuum of care till we can rehabilitate the patient and send him back to society stronger or better than before he arrived to our facility. Okay, with that, the take home 10 steps of post-resuscitative care that you need to remember and to try to carry out, which is important especially now when we get a lot of patients within the emergency department, is don't forget your airway, don't forget your breathing, don't forget your circulation. Consider you doing ECGs and cardiac intervention when necessary. Now, need to assess or determine anoxia severity. Look at the pulmonary and hemodynamic support in mild or awake patients. Consider targeted temperature management, CT brains, and other supports when patient is in a severe state or in a comatose state. Again, we need to evaluate and treat reversible causes. Doing an EEG is something that you need to consider. And last but not least is the act of prognostication of every patient which is under a care within a 72-hour period. With that, thank you very much.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning to all.
Dear Chairman, dear colleagues, ladies and gentlemen, it's a great pleasure to speak on your emergency convention, and I was asked to report about special challenges in airway management in the focus of the COVID-19 outbreak. My name is Björn Hosfeld. I'm a military physician, anesthesiologist in southern Germany, in the city of Ulm, and the specialty of anesthesiology in Germany is that the Department of Anesthesiology is responsible for anesthesia in the operating theater, for the intensive care unit, for the emergency department, as well as for the EMS, and in our special case for the helicopter emergency medical system, and for the specialty of pain therapy. So the anesthesiology covers not only anesthesia in the OR, so we are dealing with airway management in the OR, in the intensive care unit, and in the emergency department, as well as outside the hospital. So first have a look on difficult airway in the operation theater. In the operation theater, the rare cases of difficult airways are managed by very experienced teams, which can rely on senior consultants as backups. Patients are fasting. They are mostly physiologically stable and very well known, and bedded on the OR stretcher. They are accessible from all sides, 360 degrees all around. And in case that laryngoscopy fails, there are a great bunch of alternative airway devices. So in the OR, we got an experienced team, and we have a well-known patient and many devices to deal with any kind of problem. But if we leave the OR just to the intensive care unit, we meet a very high experienced team in intensive care medicine, but airway management isn't their daily business. But also on the ICU, which is still in the hospital, in case of any airway problems, the colleagues and the whole team can rely on a senior consultant as backup. The patients are mostly fasting, but they are often physiologically already compromised. For example, the patient is in a pulmonary bed condition and is already ventilated with non-invasive ventilation, and the decision for intubation is just last matter. Different from the OR, especially the bed head access is restricted by a lot of equipment like syringe pumps, ventilators, monitors. So we still have access to the patient from 3 sides, but not all around. And the bed head access for airway management is probably the most important one. And the alternatives in case of laryngoscopy failure are reduced compared to the OR. And it's similar if we look to the emergency department. A special situation is if we look outside the hospital. In the EMS system, the experience of the medical team is not comparable to the experience in the OR in most of the cases. And the emergency physician and the paramedic have no chance for any backup. They have to deal alone with the situation. Patients in out of hospital emergencies are never fasting. They are more than on ICU, mostly physiologically compromised, and the access to the patient is restricted by the patient position, lying either on roadside or in narrow rooms or on stairs, in workplaces, whatever. And the alternatives are limited to supraglottic airway devices and the surgical airway. The problem is that physiological derangements are often described already, especially for hypoxemia. The rate of these hypoxic events during emergency airway management outside the hospital is described between 10 and 20, and in one older study from Southern California up to 57%. Knowing that the emergency patients have a very limited ability to tolerate prolonged intubation attempts. In a big study in his emergency department in Tucson, Arizona, John Seckles reported adverse events in 14% of every ETI attempt just when ETI was successful on the first attempt. But this number of adverse events raised to 47% if just the second laryngoscopy attempt was necessary to facilitate intubation. So from this results, Bill Hinckley formed a very well-known slogan, -1A, definitive airway sans hypoxia on the first attempt, which is well promoted in very interesting and very good lectures from Scott Weingart on MGRID, for example. And from different papers, we know already that we have a good chance to optimize the first pass success if we use a videolaryngoscope. So in our department, we started to look for videolaryngoscopy in 2007, tested several devices, and decided to introduce the CMAC of the company Storz to the department in 2008. We started to get experience with this device in the operating theater. Then we introduced the CMAC to the helicopter, as we recognized that we get higher first pass successes, and this was very important for us for the pre-hospital emergency. And a little bit later, we introduced the CMAC to the emergency department and the ICU. So now we use CMAC on a daily routine for any anticipated difficult airway. We learn to use it for the training of our novices, because it's very easy to use the CMAC videolaryngoscope with a Macintosh-shaped plate and use the monitor just for the trainers. So the trainee has to use the CMAC as a direct laryngoscope in the traditional way, and the trainer can control and give hints with a view to the monitor. We use CMAC for every intubation out of OR, so on ICU or in the emergency department. And we use the CMAC in every emergency airway, especially out of hospital. Since we started with CMAC 13 years ago, the hospital or the military purchased more and more devices, and we changed now ahead of the COVID situation to have a CMAC on every workplace in the OR. So we use the CMAC not only for anticipated difficult airways, but for every airway. And if you use a video laryngoscope on a daily routine for every airway procedure, which is about 10,000 throughout the year at our hospital, these regular use makes single-use devices very expensive. So we rely on reusable plates. As you experienced yourself in the spring of 2020, the COVID pandemic reached the whole world. And it was a difficult situation, not only for emergency treatment, not only for the intensive care units, but especially for those who deal with emergency or with airway management. Because aerosols seem to be a problem of infection. So the first literature we got to know was a paper from the Wuhan's experience and the use of a proper personal protection equipment, the avoiding of aerosols, and the minimizing of intubation time was recommended. Several solutions were introduced to the market and especially promoted via internet. One of these solutions were such intubation boxes. These intubation boxes were made of clear plastic to cover the patient's head. It was not clear if really the whole team, the whole anesthesia team was protected, but it was a protection especially to the performer on the bed head of the patient who should perform the airway management. The problem was that the provider's arms are fixed in the holes of the boxes, and the movement in case of any difficulties was not as good, and especially for situations out of the operation theater, these boxes were difficult to transport. So another solution promoted especially via internet were plastic shields to cover the patient and to perform intubation underneath these shields. Just such foils are easy to transport, but the instrumentation underneath is difficult because the assistance with the tube, with the bougie, with blocking the cuff and so on is more difficult underneath such a plastic shield. And for awake patients, it was a kind of stress to be covered under plastic. So for our department, we decided to perform airway management in the COVID area, especially in the beginning when there was no testing of the patients, exclusively by very experienced performers. This was a problem for our young colleagues because they got less training in airway management. We also decided to perform only endotracheal intubation, and we did not rely on supraglottic airway devices, which again were the problem for our young colleagues throughout the last year because they got no training in supraglottic airway devices. All the performers had to wear a proper PPE consisting of a N95 mask, a single-use coat, gloves, in the beginning double gloves, and a face shield. And to keep distance from your own airway to the patient's airway, it was recommended to use a videolaryngoscope exclusively. One of our main slogans is train as you fight and fight as you train. So our idea is to do the same way of airway management in emergencies in or outside the hospital as we do on a daily routine in the operating theater. And as you can see in the left picture, we use the CMAC in the operation theater with a bigger monitor on a stand beside the patient. Different from the OR, where the CMAC monitor is placed on a stand, using a pocket monitor, which is placed on the handle of the videolaryngoscope, as you can see in the picture, performers are still close to the patient airway. So we asked the company of Storz to make a cable which we can put between the handle of the laryngoscope and the small monitor. And with this cable, it was possible, even in the out-of-hospital setting or in the emergency setting outside the OR, to place the monitor in a good site for the intubating physician without getting too close with your own airway to the probably infected patient airway. So this was our change in airway management during the COVID-19 pandemic. At the moment, the situation in Germany is getting better each week, and patients are, in most of the cases, tested before airway management is performed. So we have good information about the risk of infection. As a conclusion, our idea was to be fast in airway management, to reduce the time of aerosol contact. We aim to improve the first pass success as high as possible. And for this idea, we used a videolaryngoscope as first line in every intubation. And with the slogan, train as you fight and fight as you train, we tried to do the same kind of airway management outside the OR and outside the hospital as we do it on a daily routine in the operating theater. Thanks for your attention.
Good morning and warm welcome to everyone. Thank you for joining us for today's lectures in Symposium 3. My name is Nurishadiza Shamsuddin and I am the chairperson for today. Now, I'd like to introduce you all 6 amazing speakers. The first speaker, Dr. Muhammad Faiz Bahirin. He is an emergency physician from Hospital Tuanku Jaafar Seremban. He will be sharing with us on non-invasive ventilation, do's and don'ts. Next speaker, we have Professor Dr. Guido Tavazi. He is a consultant intensivist, anesthesiologist researcher, anesthesia and intensive care department, University of Pavia, Italy, and he will be presenting on helmet and IV, the practical approach. The third speaker, Dr. Chan Pei Fong. She is an emergency physician, Hospital Raja Permaisuri Bainan Ipoh Perak. She will be talking on high flow nasal cannula. Next, we have Dr. Gabriel Via. He is a senior consultant, Department of Cardiac Anesthesia and Intensive Care from Lugano, Switzerland. He will be sharing with us his view on lung ultrasound in monitoring in mechanically ventilated patients. Next, fifth speaker, Dr. Azma Haryati Ahmad. She is a consultant emergency physician practicing in Hospital Raja Permaisuri Bainan Ipoh Perak. She is Honorary Secretary of Success Malaysia and Ipoh Emergency Critical Care Society. She will talk on monitoring driving pressure and respiratory rate. It's all you need. The last speaker of the day, Dr. Cheong Chi Yen. He is an emergency physician from Hospital Raja Permaisuri Bainan Ipoh. He will be sharing on care for the mechanically ventilated patients. Now, without further ado, I would like to invite all the speakers to the Zoom platform.
Assalamualaikum and a very good afternoon, and thank you for the kind introduction. I'm Faiz and I'll be talking about non-invasive ventilation, NIV. It is a huge topic and we can talk about NIV all day long. So I will mainly concentrate on the basic of do's and don'ts in NIV, and I hope you will enjoy it. This is the outline of my presentation, some introduction, and we will see what the do's and don'ts are and some take-home messages. As an introduction, the history of NIV dated back to 1940s, where the first PEEP was introduced. And during the 50s, negative pressure ventilation had been used in the polio epidemics, and past 20 years has shown extensive usage of NIV in acute respiratory failure. So what is NIV actually? It basically refers to administration of ventilatory support without using invasive artificial airway. And we know its primary aim is to reduce the effort, reduce the work of breathing, while at the same time increase FRC and improve oxygenation. So ultimately, what we want is to avoid endotracheal intubation. Now here comes the more interesting part on how to master your NIV art. These are the do's, which I think quite relevant to us. Do pick the right NIV type, do select the right patient, do choose your settings wisely, and do estimate patient's response. And these are the don'ts, things you should avoid doing. Do not use it in moderate to severe ARDS, and do not forget the contraindication of NIV. Let's go to the first one. Do pick the right type of NIV. We have 2 types of NIV, the CPAP and BiPAP. CPAP is basically continuous positive airway pressure, and it works by stenting open the alveoli, reducing shunting, decreasing preload, and myocardial demand as well. On the other hand, we have your BiPAP, which is basically your bi-level positive airway pressure. So it works by providing 2 different pressures, namely the IPAP, inspiratory, and EPAP, which is expiratory positive airway pressure. Now, increasing your EPAP, which is more or less your PEEP, will increase the FRC and improve oxygenation status. And in your BiPAP setting, we have the delta pressure, which is the pressure difference between your IPAP and EPAP. Some call it pressure support. And this is the one affecting the ventilation. So you want to increase the delta pressure to get a higher tidal volume to improve the ventilation. So again, do pick the right type of your NIV. Are you having oxygenation or ventilation issue? Or do you need CPAP or BiPAP? So choose wisely. The second one, do select the right patient that is suitable for NIV. So which patient is suitable for NIV? So basically you can use it in both hypoxemic and hypercapnic respiratory failure. In hypoxemic respiratory failure, the problem now is with oxygenation. So you want to choose your CPAP. Best evidence of CPAP use is in your pulmonary edema, as it reduces mortality and intubation rate. Be very careful in pneumonia. We have less evidence and do not use it in moderate to severe ARDS. For hypercapnic respiratory failure, we have an issue with ventilations. So best NIV setting would be your BiPAP, and best evidence is seen in COPD patients, which was proven to reduce mortality and intubation rate as well. We have less evidence in asthmatic patients, so be very careful. Next is do choose appropriate NIV setting. You already know the difference between your CPAP and BiPAP, when to use which. What is your IPAP, EPAP, pressure support, delta pressure? Now let's have a brief look on how to initiate your NIV. A good starting point is by putting your IPAP at 10, EPAP at 5, so the delta pressure is now 5. Remember, to improve oxygenation, increase your EPAP, and to improve ventilation, increase your IPAP. And it is paramount to maintain difference between your IPAP and EPAP. For example, here you have IPAP of 10, EPAP of 5, delta pressure of 5. So your patient is having hypoxemia. So you want to increase the EPAP to 8. So what's the issue here? Remember, you have to maintain the delta pressure. If you increase your EPAP without changing your IPAP, like in this case, your delta pressure becomes 2, this will lead to reduction in driving pressure, leading to a lower tidal volume, and sooner or later, you will face ventilation issue. So keyword here again is maintain same pressure difference between your IPAP and EPAP. The final do's, which I think very, very crucial, and everyone who is using NIV should really master this. Do estimate patient's response. In other words, do monitor your patients. Putting your NIV to a patient without monitoring is like letting a car drive without a driver. So that is very irresponsible, reckless, and dangerous. So please monitor your patient during NIV. We have several things that we can monitor, like monitoring the clinical parameters, gas exchange, cardiac and lung function, and you can use the monitoring tool as well. Now let's dig deeper and go to the first one. Do monitor the clinical parameters. You have a never-ending list here on what clinical parameters you should actually monitor. And some of the most important ones include comfort, tolerance, RR, GCS, and many others. If one of these parameters is not right, for example, your patient is getting more dyspneic despite of NIV, you should attend to the patient and tackle the problem. So look and observe the clinical parameters during NIV. Another monitoring that you have to look into is monitoring of gas exchange. According to many guidelines, oxygen saturation should be continuously monitored. And of course, the target of SpO2 with different types of patient population will be different because heterogeneity of disease itself. For example, target SpO2 in hypercapnic respiratory failure, 88 to 92 is sufficient enough. And the gold standard, of course, is your ABG, and you should have a baseline taken 1 to 2 hours after NIV to see any positive or negative response. And it will help us in finding the probable solution to this problem. How about ETCO2? Like in intubated patient, it is not really accurate due to physiological dead space. Yeah. So again, you can use your SpO2 monitoring continuously, and you can use your ABG as well. Let's move on to cardiac monitoring. During NIV, the positive pressure will have effect on both our preload and afterload of our right and left ventricle. In one study, high CPAP pressure will reduce the cardiac output by 20 to 30%. But we have to know the overall consequences of NIV depends on underlying condition. For example, if patient is hypovolemic while using NIV, then this is not good because your RV and LV preload will decrease, leading to more hypotensive episodes. So you really have to monitor the cardiac function during NIV. But how? We have several simple ways to monitor cardiac function during NIV. So number one would be go back to your clinical. Look at the perfusion and pulse volume, whether it is sufficient. Look at the blood pressure and heart rate. Do one ECG. And you can apply your cardiac POCUS, point of care ultrasound, to assess the systolic and diastolic function. This is the example of cardiac POCUS, where you can see in the first video on your left, in apical four-chamber view, a bad LV systolic function. And in the second video on your right, you can see on posterior short axis, a globally hypokinetic heart. And this is not good. If you want to win the positive pressure, your NIV, of the patient with this heart condition, it will lead to flash pulmonary edema. So with this information, what can we do? So this tells us that we should optimize patient's heart status so you can start your nitrates or diuretics to offload the patients. And next is diastology of the heart, which is equally important. You can measure the EA or EE ratio to really look at the diastology of the heart, whether this is the primary cause of heart failure, and it can really tells us patient's condition during NIV. But most importantly, is all the information that you get, combine it and formulate a way so that you can move and bring the patient on the correct path of treatment during NIV use. Now let's have a look on the respiratory system monitoring, which is equally important. Again, look at the clinical, look at the respiratory rate, effort of breathing, SpO2, is it okay? And you can utilize your lung ultrasound to look at lung aeration and pathology. You can use it to look at pleura and diaphragm function as well. It sounds complicated, but it is not. So now let's have a look one by one. This is an article on lung ultrasound for monitoring of ventilated patient. Although this article is meant for ventilated patient, it can be adapted to our NIV patients. So basically, you want to assess the global function of the lung. So you divide your thorax into two hemithoraces, your left and your right hemithorax. And each hemithorax should be divided further to other 6 regions. So you have now a total of 12 regions, and you can give a score to each region. To score it, quite simple. You have a score of 0, 1, 2, and 3. 0 point for A lines, normal aerated lung. 1 point for well-separated B line. 2 points for coalescent B line. And 3 points for consolidation, which indicate total loss of lung aeration. So let's summarize this. We have a maximum of 12 regions, maximum of 3 score each region, and you get a maximum of 36 score for the whole lung. So how would you apply this for respiratory function monitoring during NIV? So you can do the scoring during the initiation of NIV, and you can do it serially after 1 to 2 hours to see the response. If the score, for example, reduces from 30, it goes down to 10, then this is a good positive sign. So this is how you can utilize your lung ultrasound in NIV to monitor the global function of the lung, and it can guide you through the process, whole process of NIV. And this is assessments of pleura using ultrasound. You can see a massive pleural effusion. So if you really want to improve patient's lung function, you should consider pleural fluid aspiration before weaning the patient off the NIV. Next is on using ultrasound for diaphragm assessment. You have on your left side the assessment of diaphragmatic excursion. Basically, it's like TAPSE and MAPSE of the heart. The more it moves, the better is the function. If the movement, the distance is more than 2.5 centimeter, then we are happy. On your right side, you have your thickening fraction of diaphragm. We can also use this because you know that during inspiration, the diaphragm will contract and thicken, and it thins out during expiration. So the difference between these is what we call the thickening fraction. And you can use the below formula to calculate, and we take the cutoff point by 30% to say it is dysfunctioning or not. This is the diagram to demonstrate the way to do it. The excursion can be done by putting your echo probe directed cranially, and you can measure the excursion, the distance using M mode. And your thickening fraction can be measured using your linear probe at zone of apposition of diaphragm and lung, and you can use the previous formula to calculate it. But more importantly, in conclusion of respiratory system monitoring, gather every information that you know, combine everything that you get, the clinical assessment, ultrasound scoring, pleural and diaphragm assessment, to give you an impression on your patient, whether they are doing well or not. And last but not the least, NIV monitoring tool. We have NIV monitoring tool, which is easy to use. Number one, your RSBI. Number two, your HACOP. RSBI is initially developed for weaning patient of mechanical ventilation, but of course, it can also be adapted in our NIV use. RSBI is basically your rapid shallow breathing index. It's basically your RR, your respiratory rate, divided by tidal volume in liter. If it is more than 105, then this is a good predictor to NIV failure. So be very careful. HACOP score is another tool in which I think everyone is using it. It has many variables, this whole list, and a score of more than 5 at 1 hour predicts more than 80% of failure, regardless of etiology. So it is easy to use, and it can help us greatly in monitoring our NIV patient. We are done with the dose. Now let's talk about the last part, very short, the dose in NIV. As I said, do not use it in moderate to severe ARDS, and do not neglect the contraindication. The contraindication is a long list again, and these are some of it. And remember, do not do any harm to our patient, and know the contraindication by heart. And with regards to the use of NIV in ARDS, patient with a PF ratio of less than 150, which is moderate to severe ARDS, has higher mortality rate with the use of NIV. And you can see the more severe the ARDS is, the higher NIV failure and the higher the mortality is. So do not use your NIV in such condition. So we have come to the end. As take-home messages, know the keys to successful NIV and keep this mantra in your heart. Start early. Initiate your NIV before patients becomes more tired. Number two, start slow to improve their comfort and tolerance. Number three, start smart. Know about the indication, contraindication, and initial settings. And most importantly, number four, start monitoring. Look at the clinical status, gas exchange, cardiac and lung function. So again, the mantra for successful NIV, start early, start slow, start smart, and start monitoring. NIV is a life-saving option, I must say, and its use is supported by robust evidences. However, to use it, we really have to stick to basic concepts, the do's and don'ts, because these are the keys to mastering the art of NIV. These are my reference, and with that, thank you very much, and I hope to see you guys again in the near future. Thank you very much.
Good day to everybody. It's a great pleasure to be here. And I would like to personally thank Adi Osman for the honorable invitation to this great meeting. In the next few slides, we're going to go through the usefulness and the practical approach of the helmet's non-invasive ventilation in a critically ill patient. So starting from the beginning, from the background, we do know that the positive pressure ventilation has some very important effects on the heart-lung interaction, which are summarized in these slides and next couple of slides, which may affect either in a positive or in a negative way, depending on the cardiac chambers that we are looking for. Regarding the venous return, we know that the venous return is determined by the gradient between the intra-abdominal and the right atrial pressure. So the application of an increased intrathoracic pressure will determine a reduction in the venous return, as in turn, an increase in the right ventricular afterload with a potential increase in the pulmonary vascular resistance. To the respect of the left ventricular function, we know that the positive pressure ventilation application may have some very favorable effects. Has been demonstrated in some studies. One of the seminal studies published more than 25 years ago on the circulation. And these patients were chronic heart failure patients undertaking the positive pressure ventilation. And the authors monitored the esophageal pressure during positive pressure ventilation and during the recovery after the positive pressure ventilation. And what they observed was that there was a significant increase in the esophageal pressure in patients undertaking positive pressure ventilation with CPAP, with a significant reduction of the left ventricular transmural pressure. This is a particular importance. Just a recall of what is the transmural pressure. It's just the intramural pressure minus the extramural pressure, generally speaking. If we apply it to the heart and lung interaction to the left ventricle, we will easily understand how it may turn into a beneficial effect on the hemodynamic. So talking about easy numbers, if we do have a pressure of 100 into the left ventricular chambers, and we do have a negative intrathoracic pressure as it happens during the spontaneous ventilation, just applying the formula above, we are going to see that the transmural pressure will be positive. Then if we apply the PEEP, the end expiratory positive pressure, and we apply the formula that we just did, we will see that the application of the positive pressure ventilation will lead to a reduction of the transmural pressure. Well, the reduction of the transmural pressure will result in improvement of facilitation to the left ventricular ejection related to the reduced afterload. So those are the two simple rules of the positive pressure ventilation in a heart-lung interaction. Going to the non-invasive ventilation, we know that there are many interfaces. There is a nasal mask, there is a full face mask, or nasal mask, and the helmet. Then we're going to focus on the helmet. And we're going to focus on the helmet, although there are less amount of studies focusing on the efficacy and the compliance of the helmet in comparison with the full face or oral nasal mask, which are more applied actually in many countries of the world. So going straight to the helmet position, we know that with the helmet, we are allowed to perform two different ventilation. The first one is the CPAP. And the CPAP, which is mainly made and functioning with, I'm showing here the Venturi setting with a double air oxygen flow meter with and that allows us to determine a fixed FiO2 and a fixed high flow. And you know that the high flow is by applying the physical rule, the reason why we are able to pressurize the helmet. There is the PEEP valve. The other very important feature is the sealed neck that allow to maintain the pressure within the helmet and also may allow to decompress just in case overpressure will be determined by an imbalance of the high flow, especially if the flow meter is not appropriately set. And then we got also a couple of holes to allow the nasogastric tube to get out from the helmet, whether the prolonged non-invasive ventilation will be scheduled. Here is how we perform the CPAP. So on top of what we have just seen in the previous slides, the other very important part to apply and to add to the circuit is the star ball. Just in the middle of the circuit is a silicon star ball that will allow an increased distanceability and increase volume flow to keep a more constant pressurization of the CPAP helmet. While the other very important thing, especially during the weaning phase, is to monitor the pressure within the helmet CPAP. So this is the way we do. The other ventilation that is allowed by the helmet is the non-invasive ventilation. It has a slightly different helmet, although made by the same composites. You can see that beside the PEEP and the flow and the FiO2, this kind of ventilation requires actually to be connected to a mechanical ventilator and allow you to set up a number of additional parameters to better control what is the aim of your non-invasive ventilation, which is oxygenation, work of breathing, but also to increase the help that we are delivering to the patient by setting up pressure support, by deciding expiratory trigger. And this is actually particularly suggested in patients that do not just have the problem of oxygenation and maybe cardiogenic pulmonary edema, but also have a problem of hypercarbia and alteration of the respiratory drive. So they do need actually an increased help to maintain the effectiveness of the respiration. And this is a study that's been published almost 10 years ago by our group in Pavia. And they actually test and improved, as it's been demonstrated in the design and the drawing of the previous slide, a way to improve the effectiveness of the non-invasive ventilation by adding actually two different limbs to the helmet, inspiratory and expiratory limb. By dividing them, the PEEP constant and the effectiveness of the gas exchange delivery was improved rather than just using one single branch with the two limbs in just one tube. And again, practical approach, this is the way that we do it. Starting with the patient with the non-invasive ventilation require then an additional support to perform and to deliver gas exchange and to relieve the work of breathing in hypercarbic patients, starting from a PEEP of 10 with a pressure support, intermediate pressure support of 12-15, and with a inspiratory trigger or roughly 3 minutes per liter. It's extremely important to titrate to avoid the auto cycling and the auto triggering, the inspiratory trigger. And with actually quite fast TI in terms of seconds. So let's go to the evidence and to some studies demonstrating the usefulness of the interfaces that we have just went through. So those are two papers published 5 and 6 years ago, and published by the biggest scientific societies regarding acute heart failure and cardiogenic shock in Europe, which are the AAC-ICM and the Heart Failure Group and the European Society of Cardiology. And you can easily see that the non-invasive ventilation, either invasive if needed, along with the echo, I'd like to underline, are lung and cardiac echo, are suggested within the very beginning of the band algorithm to treat the patient with suspected heart failure and cardiogenic shock. This is just made by the evidence of the heart and lung interaction that we have just seen, and by the vicious spiral of the ischemic heart disease, so cardiogenic shock as well. And the pathophysiology of the cardiogenic pulmonary edema in acute heart failure. We have to recruit the alveoli, and we have to maintain an adequate PaO2 to improve the delivery of oxygen to the suffering tissues due to the primary cardiac dysfunction in such a setting. So CPAP, non-invasive ventilation, key treatment goals in the very early stages of acute heart failure and cardiogenic shock by recommendation. On the other side, on the European Respiratory Journal, from the recommendation of the intensive care people, here are the certainty of evidence and recommendation in patient with acute respiratory failure. You see that there are a number of variables and number of clinical indication, including cardiogenic pulmonary edema, hypercarbia with COPD exacerbation. But surprisingly, no recommendation were made on the de novo respiratory failure. These will change after what we have lived, and we are still living with the COVID pandemic. But since 4 years ago, we did not have certainty of evidence regarding the application of non-invasive ventilation for de novo acute respiratory failure. Well, let's see some studies. Here is the differentiation the application of helmet CPAP versus oxygen therapy in severe hypoxemic respiratory failure due to an infective disease of the lung, parenchyma, and pneumonia. Not surprisingly, what came up is that there was a sudden and very significant increase in the PaO2 FiO2 ratio in the patient with CPAP, as well as the cumulative probability of avoiding orotracheal intubation in patients treated with non-invasive ventilation, with a huge difference in terms of this outcome. This is another study. I have to say quite old. It was from the seminal study starting to investigate the role of different interfaces. But it's quite eloquent in terms of results. Here is the CPAP delivered by mask and delivered by helmet. And what you can see is the constants of the respiratory effort, the amount of respiratory effort that were made by the patient undertaking different interfaces. And you can see with the helmet CPAP, the respiratory effort of the patient, of the extreme respiratory effort, either low or high, were actually more constant and with less swings, extreme swings in comparison with the patient treated with non-invasive ventilation and mask. Here is another study always published on intensive care medicine of patient treated with helmets, non-invasive ventilation in a patient with hypoxemic acute respiratory failure. You can see two different results here. First one is about hours, so time of CPAP and the tolerance, and also the difference in terms of efficacy. And what you can see also is the Kaplan-Meier survival curve of patients treated with mask or helmets on the right side of the screen, with the patient with hematological malignancy, so patient very sick with on top respiratory failure, were more likely to die after the first days if they were treated with mask. So more efficacy for the helmet non-invasive ventilation. Then I'm going to show you this study has been recently published on intensive care medicine. It's extremely important because it tells us how to evaluate at the bedside the efficacy of the non-invasive ventilation in terms of hemodynamic and the respiratory parameters through a score, the so-called HACO score, taking into consideration the heart rate, acidosis, consciousness, oxygenation, and respiratory rate in order to predict the failure in hypoxemic patient. What you can see here at different time points, you get an exponential and stepwise increase in NIV failure, so mechanical ventilation requirement, with an increase of such an ACO score in terms of points, so worsening of the variables that made the ACO score, with a very significant area under the curve and a very good positive and negative predicted value. So this is a good way to assess patient undertaking non-invasive ventilation to predict the failure of it. This is a nice randomized clinical trial with a very small number of patients published on JAMA 5 years ago. They randomized patients receiving either helmet CPAP or face mask and assessing the rate of endotracheal intubation with mild to moderate acute respiratory distress syndrome. Here is the flow chart, and here are the results. Again, quite eloquent, I have to say. Duration of non-invasive ventilation was way lower for the helmet CPAP rather than face mask. Sorry, it was lower without a significant p-value. But the p-value was absolutely significant for the level of PEEP and the constant of PEEP. For the required pressure support, is indirect sign of the patient needs for additional help to deliver the respiratory cycle, and the amount of FiO2. Also, the application of helmets, non-invasive ventilation, led to a significant reduction of the respiratory rate after randomization. And also in terms of primary outcome, endotracheal intubation. And you can also see on the right side of the screen a probability of survival using helmet CPAP versus face mask in favor of the helmets and IV. So this was the bunch regarding the respiratory failure. Here, just 2 or 3 studies more to highlight a couple of things in patient with cardiogenic pulmonary edema. This is the first study published in 2007 on European Heart Journal. Randomization of patient receiving positive heavyweight pressure. so CPAP, basically, and no surprising effects. Improved in terms of respiratory rate reduction, PaCO2 reduction, and PaO2 and FiO2. So goal achieved in terms of the aim of the positive pressure ventilation in acute heart failure. Here is a meta-analysis. There are some others that just analyze the few studies, actually, there are not many. And this is the other point. It's not a huge investigated field, especially regarding the setting of a non-invasive invasive ventilation in cardiac patients. But basically, almost all the study and the meta-analysis was positive in favor of helmet CPAP versus standard therapy in patients with cardiogenic pulmonary edema. You all know this study has been published in the New England Journal of Medicine many years ago. They randomized the non-invasive ventilation, either CPAP or non-invasive, with the positive pressure ventilation. So combining actually the two different kind of ventilation versus standard oxygen therapy. What they observed was a trend in improving the probability of survival in patients treated with the non-invasive ventilation versus oxygen alone, although no huge and significant difference existed between the two different interfaces and way to deliver the positive pressure ventilation. So coming to the end, this is an excellent study performed by the group of Adi Osman, which is actually under submission on the European Journal of Acute Cardiovascular Care. And they recognize the low number of studies investigating, and especially in a randomized patient, the non-invasive ventilation with different interfaces. And they decided to randomize patients with suspected cardiogenic pulmonary edema, either receiving helmet CPAP or high flow nasal cannula that we know that may deliver a certain amount of PEEP, but the main action of such a device is to wash out from the CO2. And they use the HACO score and set up the respiratory rate as a primary endpoint. What they observed was that there was a significant reduction of helmet CPAP of respiratory rate. So primary endpoint was satisfied in the helmet CPAP as compared with a high flow nasal cannula. A significant reduction in the HACO score with an improved in PEF ratio and in mean arterial pressure. So both sides, respiratory and hemodynamic, were improved by using the helmet CPAP as compared with high flow nasal cannula. So, as I said before, just few evidence and some of the key studies that demonstrating that the positive pressure ventilation by physiology alter the heart-lung interaction, improving hemodynamic profile and oxygenation. The interface plays a fundamental key role, both in terms of indication, PEEP, so recruitment versus and oxygenation versus recruitment, hypercarbia, oxygenation, and inspiratory trigger, and may improve the duration, reduce the shunt created by respiratory failure, reduce significantly the work of breathing, and may be more comfortable because it leads to a less sedation than the phase nasal cannula. What we have to acknowledge actually is that we definitely need more studies in heart failure and cardiogenic shock patients, both in terms of interface selection and setting of the invasive and non-invasive and invasive mechanical ventilation. Thank you again for your attention and for invitation.
Thank you for joining this lecture. I'm going to speak about high flow nasal cannula, the mechanism of action, the use at ED, including in COVID-19, and the monitoring of high flow nasal cannula using ROX index. High flow nasal cannula is a form of oxygen therapy that provides heated and humidified high flow oxygen to the patient. If you are using this device on a ventilator, there are possible 3 ventilator settings. The first is the flow rate. Usually I'll start low at around 30 liters per minute until the patient gets used to the device. Then I can increase it up to about 70 liters per minute. The next will be the oxygen concentration. If in the form of percent, you can dial from 30% until 100%. Or if it's in the form of FiO2 from 0.3 to 1. The last is the temperature, which is usually set at around 36 degrees, the body's temperature. Apart from providing a high concentration of oxygen, the high flow of gas washes out the upper airway. This prevents rebreathing of carbon dioxide and decreases anatomical dead space. The high flow nasal cannula also supplies positive airway pressure at around 1 centimeter water per 10 liter of flow rate. For example, if you put 30 liter per minute, you will get a PEEP of about 3. 40 liter per minute, a PEEP of about 4, and 50 liter per minute, a PEEP of 5, provided the patient do not open his mouth to keep talking. The mechanism of action of high flow nasal cannula is summarized nicely by Rebel EM website in the form of this mnemonic high flow. H stands for heated and humidified. I for the inspiratory demands met by the elevated peak flow rate. F, functional residual capacity, increase likely via the delivery of PEEP. L for lighter and more tolerable. O for the oxygen dilution being minimized by the high flow demand. And W washes out the dead space as mentioned earlier. The most important advantage of HFNC is it is more comfortable compared to the conventional NIV. This ensures compliance for the patient. I will discuss the use of HFNC in acute hypoxemic and hypercapnic respiratory failure as a pre-oxygenation tool and in post-extubation as a prophylaxis to prevent re-intubation. Florali trial is the landmark study that popularized HFNC in acute hypoxemic respiratory failure. In this multi-centered randomized control trial, HFNC was found to be non-inferior compared to NIV. In a subgroup analysis on moderate hypoxemic patients, those with PF ratio less than 200, HFNC was associated with reduced incidence of intubation compared to the NIV and the standard oxygen group. The probability of survival at 90 days were also significantly higher in the high flow oxygen compared to the standard oxygen and NIV group. We know the role of NIV in the form of BiPAP is established in hypercapnic respiratory failure, especially COPD. But what about high flow nasal cannula? Huang et al. Published a meta-analysis last year and found that between high flow nasal cannula and NIV, there was no difference in respect to intubation rate and mortality. The authors concluded that HFNC was a safe alternative compared to NIV when it is unsuitable for NIV in mild to moderate hypercapnic patients. The use of HFNC as a pre-oxygenation tool was popularized by this term THRIVE. This THRIVE study was done by Patel and Norrell in 2000 2013 and published 2 years later. They coined this term transnasal humidified rapid insufflation ventilatory exchange, which means that they use the high flow nasal cannula before the intubation and during the intubation process. It was found that the average apneic time was 14 minutes and none of the patients desaturate below 90%. The patients were all having difficult airways. So this high flow nasal cannula helped to prolong the time of apnea during intubation. When high flow nasal cannula was compared with NIV in the Florali-2 trial, the evidence showed that there is no difference between these two devices when used for apneic pre-oxygenation in the occurrence of severe hypoxemia during intubation procedure as well. What about post-extubation? Dr. Fernandez and team published 3 randomized control trials on this issue. In the first trial, high flow nasal cannula was compared to conventional oxygen therapy in low-risk patients. And it was found that high flow nasal cannula reduced the risk of re-intubation. In the second trial, high flow nasal cannula was non-inferior to NIV in preventing re-intubation. In fact, high flow nasal cannula was found to be more comfortable and at advantage compared to NIV. The third trial, the authors attempted to compare high flow with a conventional oxygen therapy in high-risk patients. Unfortunately, this trial was stopped due to some methodological flaws and low recruitment rates. But based on this first and second trial, the authors concluded that high flow nasal cannula is a powerful respiratory support post-extubation and is non-inferior to NIV. In the early days of COVID-19, most clinicians chose to intubate patients early to avoid risk of transmission to the healthcare workers. The use of high flow nasal cannula in COVID-19 later was found to decrease the need for intubation. This was published by Sun et al., where he shared his experience with using this high flow nasal cannula and the awake proning technique in Jiangsu province in China. After he described this, more clinicians start to use this technique, and this picture became viral in the early days of pandemic. It showed the picture of a lady on high flow nasal cannula playing with her handphone, and the monitor shows the saturation to be 54%. So even though the patient is very hypoxic, she is very comfortable. So the term was what we call happy hypoxic patient. So subsequently, more and more evidence start to come in, and clinicians realize maybe intubation is not the only strategy, and high flow nasal cannula gain more popularity. There are 2 concerns with using high flow nasal cannula. The first is the risk of aerosol dispersion. Contrary to popular belief, if you were to use the high flow nasal cannula and to have a proper fit of the cannula at the nostril, the risk of aerosol dispersion is quite low compared to the aerosol generating NIV, which is the most dangerous. In fact, low risk of aerosol dispersion of high flow nasal cannula can further be reduced if you put on a surgical mask for this patient. So in this study on human mannequins by Leonard et al., he found that if you were to put on a surgical mask for the patient, it can actually trap about 70 to 80% of the particles, regardless of whether the patient is using high flow oxygen, low flow oxygen, or if the patient is not having any oxygen. The risk of aerosol dispersion is much more significantly decreased if you put on a surgical mask. The second concern about HFNC is it may delay intubation because of apparent improvement in patient comfort could mask the deterioration. The use of HFNC in COVID-19 is still very controversial as the results from large RCTs are pending. Most of the critical care societies in the world recommends to use it, but WHO cautioned against using this on all patients. So high-flow nasal cannula, according to WHO, should only be used in selected patients with hypoxemic respiratory failure, usually those that has mild to moderate failure. And if you were to use this device, it should be closely monitored. The patient should be closely monitored for clinical observation deterioration. I'm going to illustrate the next part of my lecture on monitoring of high-flow nasal cannula using a case scenario. A 40-year-old lady came to the A&E with shortness of breath for 2 days. On arrival, she's having respiratory distress and she's diagnosed with pneumonia and suspected COVID-19. So she was put on high-flow nasal cannula with a FL2 of 0.7 and a flow rate of 60 liters per minute. After 6 hours, she's on awake proning, but her saturation is still at 88%. So the question is, should you intubate this patient? Besides using clinical assessment, we can use the ROX index, which is also termed as the ratio of oxygen saturation. We calculate by dividing the SF ratio from the respiratory rate. Rocker et al. First described this ROX index in 2016 to predict the success of high-flow nasal cannula in pneumonia patients in the ICU. By using a cutoff of 4.88 at 12 hours, it was found that HFNC was associated with lower risk of mechanical ventilation. This is the group with high-flow nasal, and this is the group without high-flow nasal cannula. So the area under a curve for this 4.88 ROX index is 0.74. Nearer to 1 is the best. The ROX index was validated by the same author 2 years later in a multi-center prospective observational cohort study. It was found that ROX index greater than 4.88 at 2 hours, 6 hours, and 12 hours was confirmed to be determinant of high-flow nasal cannula success. Additionally, a ROX index of less than 2.85 at 2 hours, less than 3.47 at 6 hours, and less than 3.85 at 12 hours were determinant to be the predictor of high-flow nasal cannula failure. So going back to our case scenario, the calculated ROX index was found to be 4.48 based on the saturation 88%, FL2 0.7, and the rate of respiratory of 28. So if it was you, shall you wait or proceed with the intubation? See, 4.48 is at 6 hours is between the lower and the higher cutoff point. So this algorithm was suggested to help with the intubation decision by doing a dynamic assessment. So there are 3 possibilities in this algorithm. The first is, if the ROX index is below the cutoff value, highlighted in red at these certain hours, then intubation should be considered. The second possibility is the index is between the lower cutoff and the higher cutoff value, highlighted in yellow. So for this patient at 6 hours, the ROX index was 4.47. It falls in the yellow group category. So the recommendation by the authors are to increase the high flow nasal cannula setting and to re-evaluate in 30 minutes. If after that, the ROX index drop further, less than 0.5, then intubation should be continued. And if it improves, then we can continue to monitor the patient. The last possibility is it is above the upper boundary of the cutoff value of 4.88. We can continue to use the high flow nasal cannula and monitor the patient closely. However, bear in mind that the earlier studies were for patients who were not COVID positive and they were done in an ICU setting. Recently in May 2021, Laura et al. Published a study on ROX index in COVID-19 for patients outside the ICU. However, the authors used a higher ROX index of 5.99 instead of the earlier number of 4.88. And it was found that the area under the curve was 0.78 at 12 hours. And this is a 5.99 is the best predictor of intubation with the area under the curve higher than the last study. To summarize, the decision for intubation for every case should be based on benefit and risk. After careful consideration of the clinical assessment, the ROX index, and the available resources for disposition. So my take-home messages are, high flow nasal cannula is an effective form of oxygen therapy in ED for hypoxemic and hypercapnic respiratory failure. It's a pre-oxygenation tool and for post-extubation prophylaxis. High flow nasal cannula has a role to play in COVID-19 and can be used for awake phoning. However, we must bear in mind the two main disadvantages of high flow nasal cannula. The first is the risk of aerolization, increasing the risk of healthcare worker transmission. And the second is high flow nasal cannula may delay the intubation, leading to worse outcomes. I will recommend dynamic assessment using the ROX index to monitor for high flow nasal cannula failure with a different cutoff of 4.88 for non-COVID patients and 5.99 for COVID patients. With that, I thank you.
My greetings to the audience and thanks to the organizing committee for inviting me and talk about the use of lung ultrasound to monitor the mechanically ventilated patient. I am Dr. Villa, senior consultant in Lugano, Switzerland, cardiac anesthesia and critical care. Let's start with a short premise. As you all know, lung ultrasound is based on the representation of the lung by means of either images, which always mean pathology, so there's no air where there should be, or artifacts. And these artifacts can either be normal, they usually have a horizontal orientation, or pathological, longitudinal, so they can be easily be differentiated, and artifacts always mean the presence of a variable degree of air. Let's focus on a while on what makes these artifacts so different. The pathological ones from the physiological ones. When the density of lung tissue beneath the visceral pleural is very low, lung tissue is full of air, these appear as horizontal artifacts. But when either an increase of fluid or a decrease of air characterizes the subpleural lung tissue, its density increases. And longitudinal artifacts, the B lines, appear in a variable number proportional to the density. And this entails an exquisite handiness, because we have to admit how most of our daily diagnostic and monitoring clinical activity consists exactly in the assessment of how much air and how much fluid the lung of our patients contains. So based on this premise, this is what I will briefly describe. Why lung ultrasound is a suitable yet peculiar lung monitoring tool, which are the patterns it is based on, and how should the scanning be conducted, and I'll show you the current evidence on its clinical applications in the mechanical ventilated patient, and finally propose a very pragmatical approach. So let's start by saying that observations in man during mechanical ventilation with lung separation provided an interesting documentation on how loss of air content is associated to a remarkable change in lung ultrasound findings with a striking cause-effect relationship. Lung ultrasound was performed on lungs submitted to progressive deaeration from a state of normal inflation down to complete atelectasis, and showed how from a normal pattern appearance of B lines ensue, with B lines then increasing in number and crowding, then progressing to consolidation from the periphery to a complete lung atelectasis. Bottom line, there's a continuum in lung ultrasound patterns with a progressive loss of aeration from A pattern to B pattern to B crowded to the C pattern. And on the other hand, the amount of extravascular lung water as measured with its clinical gold standard, the PICO device, correlates nicely with the number of B lines or the number of areas presenting the B pattern. This said, let us not forget how lung ultrasound investigates merely the most outer layer of the lungs. Pathologies where lesions above the surface are easily recognized. Pathologies and lesions not manifesting themselves at the surface where remains therefore undetected. So this should be kept in mind. Furthermore, while traditional radiological imaging techniques represent the lung as a whole, either from the front or as 2D slices, lung ultrasound depicts only lung segments, and the overall picture must be assembled mostly mentally. In summary, lung ultrasound acts as a surface densitometer that has the potential to track aeration and extravascular lung water changes and requires a segmental approach. So, increasing evidence already in 2012 culminated in the International Consensus Conference on Lung Ultrasound, which clearly stated that lung ultrasound has the potential to track changes in aeration of lung parenchyma and extravascular lung water, can provide a semi-quantitation of these changes, and can hence be used to monitor a series of lung diseases. So going clockwise from left upper panel, the patterns we use to monitor are the pattern of normality, just A lines, well-spaced B lines, or more crowded coalescent B lines, and finally a consolidation C pattern. So they are associated with progressive degrees of air content or increase of water in the lung. And the shift from one pattern to another during lung ultrasound monitoring can be appreciated thus qualitatively. A systematic approach should be followed, where 6 segments per lung should be scanned. You see here a patient, the landmarks are represented by the axillary lines, and we always have an upper and a lower quadrant. But although a qualitative appreciation of the change may in some circumstances be useful, lung ultrasound monitoring would better entail a quantification, a score attribution and computation. An ultrasound score of aeration can be calculated as follows. This is called aeration score. So for each given region of interest, points are allocated according to the worst ultrasound pattern observed. Normal is 0, well-separated B lines is 1, coalescent is 2, and consolidation is 3. A lung ultrasound score ranging between 0 and 36 is calculated as sum of each region of the lung. And this score is a global picture of lung aeration and can be regularly monitored. An increase in the score indicates a decrease in aeration. This is how it works. But also a lung score of re-aeration can be calculated, and this one is based on changes of the ultrasound pattern of each region of interest during an observational period. This period could correspond to a PEEP trial, prone position, or any therapy aimed at aeration improvement. In the second step, a score is given according to lung ultrasound pattern change observed in each region of interest. So for example, change from consolidation to normal, 5 points, and from coalescent to well-separated B lines is 1 point, and so on. And the reverse happens when actually deaeration occurs. So to talk about lung ultrasound monitoring in mechanical ventilation, I'll deal with the setting where actually lung disease reaches its greatest severity and mechanical ventilation its highest complexity. So I'll refer to some of the most important targets in the mechanical ventilation settings in understanding the disease. I'll talk about the use of lung ultrasound in phenotyping, monitoring disease course, monitoring or predicting the effect of recruitment and PEEP setting, and the changes that are related to pronation. I'll start very briefly addressing a few applications that actually are purely qualitative. And as recently suggested in a very nice editorial on ICM, due to its portability and nowadays widespread availability, and also as a consequence of the pandemic, lung ultrasound potentially represents the ideal diagnostic companion at the bedside of the ARDS patient, together with some simple surrogates of dead space and shunt measurements that are so readily available. Differences in the pulmonary distribution of aeration loss has a profound clinical implication and affects the ventilation strategy. So ARDS patients with gross heterogeneous distribution of aeration loss, the so-called focal pattern, with relative sparing of ventral areas, are at greatest risk of ventral overdistension and ventilator-induced lung injury of the aerated parts of the lung. So this heterogeneous distribution of aeration can be appreciated by lung ultrasound. Normal pattern in upper anterior and lateral lung regions, and consolidation in lower posterior and lateral ones. So the dependent lung regions in a supine position. In patients where aeration loss involves all the lung homogeneously, higher PEEP can be tested, so it's a so-called diffuse or patchy pattern, and the increase in intrathoracic pressure predominantly induces lung recruitment without significant hyperinflation. Indeed, as recent COVID-19 pandemic has shown, the overall extension of lung damage can be appreciated by imaging, including lung ultrasound. And when milder deaeration is detected in presence of an equally severe hypoxemia, such as the second case, specific consideration on the ventilation strategy and on perfusion-related hypoxemizing etiology should be raised. So there's been a lot of ongoing discussion on these kind of phenotypes, and these can be appreciated in terms of aeration by means of lung ultrasound. So let's now consider some data on the approach that utilizes quantification, lung ultrasound scoring. This recent study assessed the diagnostic performance of lung ultrasound in identifying ARDS morphology, focal versus non-focal, compared with the gold standard computed tomography. Mechanically ventilated ARDS patients undergoing a CT scan and ultrasound were enrolled. 12 fields were evaluated per each lung, 6 per each lung, and so 2 ventral, 2 intermediate, and 2 dorsal per lung. And the usual lung ultrasound aeration score was used to characterize each of the 12 areas explored. Patients were categorized as focal, such as the patient in the upper panels, or non-focal, according to the CT scan. And lung ultrasound findings in each of the 3 groups of areas scanned were compared with this categorization done with CT scan. So, as concerns the clinical performance, lung ultrasound overall global, and lung ultrasound in the intermediate areas and in the ventral areas actually showed the greater diagnostic accuracy in differentiating the 2 focal and non-focal. So these scores were significantly lower in patients that actually had a focal disease rather than a non-focal disease. And as you can see from the receiver operating curves here on the right, ultrasound assessment of ventral areas showed the greater diagnostic accuracy in discriminating focal versus non-focal, and an ultrasound cumulative ventral score greater or equal than 3 had the best predictive value in identifying non-focal ARDS morphology. This means, for example, that finding a coalescent beat pattern in at least 2 ventral areas can rule out a focal pattern. This is a very pragmatical application. It is intuitive to understand how dynamic variations of ultrasound appearance can track changes in lung damage. Going back here, this is a small case series of RDS patients under ultra-protective ventilation and venous ECMO. Patients' progressive healing is tracked by a decrease of the lung ultrasound score, and the median score at ECMO cannulation was 25, and you can see that for the patients who survived, the median value at decannulations was around 14. Using the reaeration score that we just mentioned, so this time is a reaeration, the one that focuses on the variation, Buemad and his group used ultrasound to assess PEEP-induced lung recruitment in 30 patients with RDS as compared to the pressure volume curve method for assessing recruitment. And importantly, a highly significant correlation was found between PEEP-induced recruitment measured by the PV curve and ultrasound reaeration score. In addition, ultrasound reaeration score correlated well with PEEP-induced increase in PaO2. This is not shown here. But very practically, a lung ultrasound score, reaeration score of 8 or more, actually was associated to a recruitment of at least 600 mLs as assessed with the PV curve. But how does ultrasound compare with the current gold standard for the assessment of recruitment? CT scan. In this example, you can see side by side the global ultrasound overall picture and a cranial and caudal CT slices in the same patient. At peak 5, both show areas of poor aeration in absence in other that actually have absence of aeration in the most dependent areas. Here you see the evident changes in terms of improved aeration both at CT scan and at lung ultrasound, where a reduction in consolidated areas and an increase in well-aerated areas can be appreciated. And this is what was assessed in a study we conducted together with Davide Chiumello from the Gattinoni group a few years ago. There was a substantial agreement in regional aeration assessment between ultrasound and CT at both PEEP levels. Regions with different ultrasound score had also different lung tissue density, and at each step of lung ultrasound score increase that corresponded to a significant gain in tissue density by CT scan. So for example, well-aerated regions which have a CT Hounsfield units between -500 and -900 actually corresponded to a lung ultrasound score of 0 or 1, while the poorly aerated and non-aerated had higher scores. But as you can see, lung ultrasound does not speak exactly the same language as CT scan. In around 30% of observations, ultrasound underestimated regional lung aeration. This mainly for two types of disagreements. The first is that actually score 2, so severe loss of aeration, was assigned to well-aerated region in some observations. So current ultrasound scoring identifies score 2 on the basis of coalescence of B lines, and where focal coalescence, not occupying much of the pleural line, actually exists. This leads to attribution of a score of more of greater severity than what actually it is. And the other source of disagreement was the fact that complete loss of aeration was assigned to poorly aerated regions in several observations where lung ultrasound limitation is attributing the score 3, the non-aerated score, whenever a tissue pattern is observed, regardless of its dimension. So altogether, changes of global ultrasound score were not statistically associated with lung recruitment defined as a decrease of non-aerated atelectatic tissue, which is the standard definition at CT scan. But lung ultrasound score changes in function of any aeration modification even are actually made, are actually observed, and even when consolidated regions are not involved. So actually lung ultrasound tracks the changes according to recruitment, although the definition is different from the one of CT scan. And a weakness of the current definition of the ultrasound score is at the base of many of this misclassification. So it does not change if a tissue pattern-like is still detected, although significantly reduced in size. This is the example on the left. And a patient with severe but not complete loss of aeration may respond to PEEP with substantial improvement of lung tissue aeration, but by definition cannot be a recruiter because potentially recruitable notorated tissue is missing, as you can see here, while vice versa, there is a change in the lung ultrasound score. So finally, a multi-center French study investigating whether a lung ultrasound pattern could predict in ARDS patients with PF minor than 150 a favorable oxygenation response to pronation. Focal pattern was defined if at least 4 on 12 normal ultrasound errors were found, and a high oxygenation response was ex post defined as at least 60% increase in the PF. So there were 4 times of observation before pronation, 1 hour after pronation, 1 hour before putting the patient back supine, and 1 hour after back to supine position, and the re-aeration score was observed, was actually used to assess the re-aeration or the worsening the aeration. As you can see from the left lower diagram, there was no difference in terms of global aeration change by means of ultrasound between the high responders, which are the green bars, and the low moderate responders, the blue bars. So to say, the intensity of oxygenation response was an average, not correlated to re-aeration. But interestingly, if you look at the right lower diagram, there was a marked difference in the regional aeration change induced by pronation between patients who had a focal and non-focal ultrasound pattern. So to say, the patients with focal pattern, they experienced at 1 hour after pronation a great aeration gain in the dorsal areas and a significant aeration loss in the ventral ones, dorsal and ventral. You can see how much the difference is. Additionally, the variation after 1 hour pronation in terms of improved oxygenation and a decrease in CO2 was significantly greater in patients with a lung ultrasound detected pattern of focal presentation, a focal morphology. So this is what ultrasound can tell you in terms of prediction of pronation. So let's conclude saying that according to the current evidence, let's see a very pragmatical approach on how to guide ventilation in ARDS patients. Lung ultrasound monitor should not, of course, be considered alone. You should actually employ the various tools that you have at the bedside, but of course it can reduce the number of CT scan and can substitute for other less available and less easily deployable tools. A potential approach is actually to look at the presentation morphology, so where focal means anterior areas that actually are well aerated, and this should limit the PEEP you reach in your trial or should consider early pronation. While if a diffuse or patchy pattern is found, what actually should be done is to aim at higher PEEPs during the trial and observe the clearance of the B lines in the anterior area. So titrate PEEP upwards until there's clearance of the B lines ventrally. And of course, the re-aeration score could provide an information of the substantial re-aeration, and anterior sliding should be preserved. Let's come to a couple of cases. This was a pediatric patient that actually was in very poor conditions, and you can see from the ventilation and gas analysis and the chest X-ray there. And the ultrasound exam showed clearly a focal pattern, spared ventral areas and marked deaeration in the dorsal ones. So what was done was pronation, and as you can see, a re-aeration in the dorsal areas was pretty quickly observed. This is another case, a very dramatic coronavirus known COVID patient some years ago, poor RDS, poor gas exchanges, very difficult ventilation. Again, lung ultrasound is performed. Clearly, this is a diffuse pattern. So overall loss of aeration not prevailing in dorsal areas. So score attribution was performed, very high lung ultrasound scores, starting from 10 PEEP. There was an increase in PEEP to 15 and then to 20, observing a reduction in the number of the B lines and a re-aeration of some areas. So this led to the actually set of a high PEEP that was not 20, because in 20, as you can observe on the right lower panel, there was an abolition of the sliding, which actually is a sign of overdistension. And also the respiratory mechanics were consistent with this. So to conclude my key messages, lung ultrasound actually can track real-time the aeration in extramuscular lung water changes. It actually tracks this on a regional and a global basis. It cannot detect lung hyperinflation nor the deep lesions, but it's suitable for assessing the severity, the presentation morphology, and as you saw, to guide ventilation and to observe the variation in the progression towards healing or worsening. And I thank you very much for your kind attention.
Thank you, Madam Chairperson, for a very nice introduction. Assalamualaikum and a very good day to all the participants. I would like to take this opportunity to welcome you to the virtual Nexus 2021 and thank you very much for your participation. And I was given the task to talk about the importance of monitoring driving pressure and respiratory rate is all you need. And I have no conflict of interest to declare. And let us start by asking these clinical questions. Is it worth to decrease tidal volume or driving pressure at the expense of increasing respiratory rate? I hope we'll be able to answer these questions at the end of my presentation. And for your information, we are going to talk in the perspective of restrictive lung disease rather than a normal lung. Right, so have a look at this picture. This is a CT scan of a patient RDS patient showing a different pathology on each side of the lung. You can see one side might have the bigger area of consolidation compared to the other part of the lung. Same goes to the other ARDS patient. They might have a different pathology. All right, and the green one here is the normal lung. It is very small, all right? So this is what we refer as baby lung due to the small area of normal lung in ARDS patient in compared to the pathological area. And the smaller the normal lung, the reduce the functional lung capacity. And the mechanical ventilation to these types of lung will associated with ventilator-induced lung injury if it's not done appropriately. So the potential for mechanical ventilation to cause harm was first described in the mid-18th century, and over 250 years later, ventilator-induced lung injury was proven definitely to contribute to mortality in patients with acute respiratory distress syndrome. And this is when later on they inspired what we call as personalizing lung protective strategy. We have 4 types of ventilator-induced lung injury. It depends on the parameters that have been set on the ventilator. You can have either barotrauma due to the high pressure delivered to the patients, or volutrauma due to the high volume delivered also to the patient, or atelectauma because of the shear stress due to the continuous cycling, opening, and collapse of recruitable atelectatic lung, or biotrauma, which follows later due to the mechanical lung injury that triggers an extensive biological response. So the increased understanding of ventilator-induced lung injury has led to several preventive strategies targeting the underlying mechanism. So we are looking into this step to achieve this and also to reduce the multi-organ failure and improve survival. So based on the protective strategy which we are performing on ventilated patient, every parameters was basically to cater each components of ventilator-induced lung injury. The targets of P-ratio less than 30 centimeter water basically to prevent barotrauma from happening, and the usage of low tidal volume to be less than 6 ml per kilo, basically to stop or halt the volutrauma from occurring. And also to achieve optimal PEEP, which might be differ from one patient to one patient, is basically to prevent atelectauma. And by managing all the parameters above and all the ventilator-induced lung injury, will later prevent the biotrauma from occurring. And have a look at this driving pressure, which is very easily calculated at the bedside as P-ratio minus the PEEP that's been set on the patients, right? You can get the value of P-ratio by looking at the pressure over time scalar and you can directly look at the value of P plateau here, or you can also perform the inspiratory hold maneuver for 10 seconds, or automatically measured by the ventilator. Look at the ventilator screen for the value of P plateau. Right, once you get the P plateau minus the PEEP that been set on the patient, you have the value of driving pressure. And this driving pressure reflects the ratio of the tidal volume to the compliance of the respiratory system. And a decrease in driving pressure was largely achieved with reduction in tidal volume and a corresponding and expected increase in respiratory rate to maintain the minute ventilation. Right. So this is the famous article by Amato and the group. All right. Should among ventilation variables or ventilation parameters, driving pressure was mostly strongly associated with survival, and one standard deviation in the increment in driving pressure was associated with increased mortality even in patients with protective plateau pressure and tidal ventilation. This study was done on 3,562 ARDS patients. And what it tells you that by looking at the graph here, all right, a lower survival rate was observed among patients with higher driving pressure compared to patient with a lower driving pressure, which later have a higher survival rate. So this is what you want to aim in your preventions of ventilator-induced lung injury and to improve patients' mortality. Right. So if you look at this graph, all right, you can see at the level of 95% confidence interval here, you can see at the value of approximately 18 centimeter water, anything beyond that cause increased mortality, and anything less than 18 centimeter water will reduce the mortality rate. Right. This is another concept to relate the degree of ventilator-induced lung injury to the amount of energy transferred from the mechanical ventilator to the respiratory system within a time-given frame. So mechanical power is basically composed of parameters set by the clinician at the bedside, such as the tidal volume, the airway pressure, right, the inspiratory flow here, and the respiratory rate, and also the PEEP, right, and also plus other several patient-dependent variables such as PEEP or PIP, P-plat, and driving pressures. And this is basically the mechanical power is basically shows you the energy that used to distend the lung, to move the gas from the upper airways to the terminal airways, and also to keep the lung open. You don't have to remember this equation. It's just the concept that you need to remember. And the Cartinoni published this concept of mechanical power in the year of 2016, in where he and the group expressed the relation between the tidal volume, pressure, and flow and in mechanical power. The higher the mechanical power is associated with the higher ventilator-induced lung injury. So in those patients where you increase the inspiratory flow by 20%, the mechanical power will increase by 37%. And if you increase the respiratory rate and then inspiratory flow together, the mechanical power will then increase to from 2 to 22 joules per minute. And the increase in respiratory rate at the similar tidal volume, meaning that you fix the tidal volume, but you increase the respiratory rate, will constantly associate with lung damage and hemodynamic impairment due to increase in minute ventilation. So what you need to do, you need to reduce your tidal volume before you increase the respiratory rate to minimize this. And if we put these two graphs together, the graph of driving pressure versus survival and the mechanical power versus survival, you can see the graph in the driving pressure is steeper compared to the graph of mechanical power, meaning that the higher the driving pressure, the higher the mortality compared to those with the mechanical power. So this is another study done by Amato and the group, and been presented in ICCAM last year, right? He basically looking at the few predictors or pre-parameters and also the mechanical power in relation to the mortality. What he found out that based on the studies, the driving pressure and the respiratory rate is associatedly or significantly associated with mortality compared to the mechanical power. Later on, what he did, he separate this mechanical power into its component, into its dynamic, static, and resistive component. And what is he found out that even after separation of this mechanical power into its component, the driving pressure and the respiratory rate remain significantly higher association with mortality compared to the mechanical power. So so when he put into another graph, so what he saw is the driving pressure graph is steeper compared to those in mechanical power, and it is significantly associated with mortality compared to the mechanical power itself. Right. So remember another two parameters, another one parameter, which is the respiratory rate. So respiratory rate also is significantly higher in relation to the mortality. But if you compare these two together, you can see the driving pressure, it is most significant variables that associate with survival. Right. So if you compare these two, you combine these two graphs together, we can see the effect of changes in driving pressure is 4 times stronger than the effect of respiratory rate. And what it tells you that more patients will die if the driving pressure is increased 4 times compared to those with higher respiratory rate. So again, is back to the our first clinical questions. Is it worth to decrease the tidal volume or driving pressure at the expense of increasing respiratory rate? So the answer is yes, right? Because why? Because the lower the tidal volume, lower the P-plateau. The lower the P-plateau will later lower the patient's driving pressure, and the lower the driving pressure will later lower the mortality based on the previous study that we already discussed. Right? So again, is monitoring the driving pressure and respiratory rate, is it all you need? Right? So what we do is basically when we set our ventilator, we always put the patient on FiO2 of 1, then you set your tidal volume to 6 ml per kilo based on the ideal body weight, and then set the rate to achieve the minute ventilation 80 to 150 ml per kilo per minute, or estimated around 7,000 mils, and then determine lung recruitability and set the appropriate PEEP. It might be differ from one patient to one patient. And then assess the P-plat. If the P-plat is more than 30 centimeter water, reduce the tidal volume by 1 ml per kilo till the P-plat less than 30 centimeter water. All right. And then you assess the driving pressure and accept the driving pressure if it is less than 80 centimeter water. If it's not, then you need to reassess again the patient, reduce more the P-plateau and increase the respiratory rate. Right? And then taper the oxygen FiO2 to be less than 0.6 if possible. Right? So in practicality, what we do is for those patients who has a 70 kilo body weight, right? If you set the tidal volume to 6 mils per kilo, you will achieve 420 mils times the respiratory rate of minute ventilation of 7,560 if you times by 18 breath per minute, right? So if the patient has higher P-plateau, what you need to do is to reduce the tidal volume to 5 ml per kilo. So this is actually a reduction by 20%. You will have lower tidal volume here. If you times the lower tidal volume to the similar respiratory rate, you will have a lower minute ventilation, which is not even achieve the 7,000 mils, all right, or it's not even similar to the previous minute ventilation. So what you need to do is you need to increase the respiratory rate by 20%. So if let's say you increase by 20%, give you the value of 21, 22 breath per minute. So your minute ventilation will achieve approximately similar to the previous one. So after you look at this improvement in minute ventilation, what you need to do is to have a look at the driving pressure. Make sure the driving pressure is less than 18 centimeter water. Whatever it is that you do, the lower the driving pressure means the improve in patient's survival, reduce patient mortality. So this is what it means by reductions of your tidal volume to make it to make your driving pressure less than 80 centimeter water. So, but again, as summary, in our busy mind to manage the driving pressure and the respiratory rate, do not forget other parameters, and it's always auto-related, right? You need to have a control delivered tidal volume, 4 to 6 ml per kilo, start with 6, and then catered based on your driving pressure, based on the P plateau, right? Need to get to have what we call as a limit P plateau less than 30 centimeter water to achieve the optimal PIP. This might be differ from one patient to one patient by using the open lung strategy, all right? And then to limit FiO2 to be less than 0.6 and to allow permissive hypercapnia, all right? Do not do this or perform this in those patients with raise in intracranial pressure or in hemodynamically unstable patient or hypotension or hypovolemia patients. So please be careful in performing permissive hypercapnia. Also, driving pressure need to be maintained less than 18 centimeter water to reduce the mortality, right? So thank you very much for listening. Again, have a good day and enjoy the rest of the conference. Thank you very much.
Good afternoon. I'm Chang Chi-Yen from Hospital Raja Permaisuri Painan Ipoh. Today I will talk on care for the mechanical ventilated patient. In emergency department, we perform intubation and initiate mechanical ventilation for critically ill patient every day. Due to the challenge of ICU bed availability, ventilated patients stay in ED for long periods of time, and post-intubation care is initiated and has to be optimized in ED while waiting for the patient to be admitted to ICU. After intubation, besides treating the condition that results in intubation and mechanical ventilation, essential components in the care of ventilated patients in ED include ventilator management, hemodynamic optimization, analgesia and sedation, supportive care, nutrition, and weaning. Today's my talk will focus on the management of analgesia and sedation and supportive care in ED ventilated patient, because I think these are the areas of improvement and these areas are less frequently talked about. First, analgesia and sedation. Ventilated patients commonly experience pain and anxiety. These are often due to the presence of an endotracheal tube, the ventilator, placements of invasive catheter, or any surgical procedure or simply routine nursing care, such as suctioning and patient repositioning. Unrelieved pain can lead to adverse effects, including increased catecholamine release, which can cause adverse autonomic and hemodynamic response, increased oxygen demand, and myocardial ischemia. Therefore, analgesia and sedation are necessary to reduce these adverse effects. Patients with adequate analgesia and sedation also experience fewer adverse dreams after their illness and less post-traumatic stress disorder. Analgesia and sedation also facilitate mechanical ventilation. How do we assess pain in patients, in ventilated patients? Ventilated patients are unconscious and unable to self-report their pain. So facial expression observation is the main method for pain assessment in this ventilated patient. Other signs of pain include hypertension, tachycardia, lacrimation, sweating, and pupillary dilatation. What is the level of sedation appropriate for ventilated patient? Previously, it was standard to provide continuous infusions of analgesic and sedative throughout the durations of mechanical ventilation. However, latest evidence demonstrates that use of light sedation and daily sedation breaks, also known as sedation holiday, reduce days on mechanical ventilation and overall length of stay. The SCCM PEDIS Guideline 2018 recommends light sedation, which is RASS score of -2 to +1 for critically ill patients. Providing appropriate analgesia and sedation is an important component of post-intubation care. What is the current practice in ED? In a cohort study looking at the sedation practice in ED, it was found that up to 30% of ED ventilated patients had no analgesia and 20% had no sedation. On the other extreme, over-sedation occurred in 40 to 60% of the ventilated patients. Sedation is usually required in ED ventilated patients. However, early deep sedation should be avoided. In a multi-center prospective cohort study, namely the ED-SET study, which was looking at the sedation practice in ED and the outcome of deep sedation, a total of 324 patients were recruited. And in this study, deep sedations were observed in more than half of ED patients, is about 53%. When compared to light sedation, early deep sedation, which is RASS score -3 to -5, was associated with acute brain dysfunction and prolonged hospital length of stay. So we can see that sedation practice in ED has consequences in patients' outcome. Inadequate or over-sedation both carries negative impact on patients' outcome. How do we improve management of sedations in ED? It requires intentional change in daily practice. According to Institute for Healthcare Improvement, protocols can help in implementation and improvement of a care process. Standardized multidisciplinary framework can ensure appropriate post-intubation sedation and analgesia. So we need protocol or sedation and strategies in this aspect. So what are the sedation strategies? First is analgesia, early and adequate analgesia. When managing ventilated ED patients, it is critical to provide them analgesia as soon as possible after intubation. Early treatments of pain with adequate analgesia can help patients to achieve a level of light sedation with minimal or less sedatives. Second is sedation. Although it is reasonable to start with analgesia in isolation, but in ED patients who are just intubated, sedative agents is usually required to keep them comfortable and to facilitate ventilation. After appropriate analgesia, sedative agents should be given to target for light sedation, except in certain conditions, for example, in patients with status epilepticus and traumatic brain injury, in which deep sedation is indicated. About the choice of sedative agent, non-benzodiazepine sedative is preferred. Study has shown non-benzodiazepine sedative reduce time to light sedation, ICU length of stay, duration of ventilation, and delirium. And we need to monitor the level of sedation. Using standardized measure of sedation, such as RASS score, can lead to more reliable and consistent sedation practice. RASS score has good inter-rater reliability and is superior to GCS in assessing sedation level. In ventilated patients, we can't assess their verbal response because they are ventilated, they are intubated. So in RASS score, the verbal component is removed. Last, we should avoid paralysis. Neuromuscular blocking agents are often given to facilitate mechanical ventilation. However, use of neuromuscular blocking agents should be limited to facilitating intubation, mechanical ventilation, particularly in severe patients' ventilator desynchrony, because prolonged use of this neuromuscular blocking agent can result in complications such as prolonged patient's immobility, critical illness polyneuromyopathy, pressure sore, nerves injury, and risk of DVT. This table shows the commonly used medication in ED, analgesia, and sedation. The commonly used medications are morphine, fentanyl, midazolam, and propofol. Opioid is the drug of choice for analgesia in intubated patients. Fentanyl is preferred over morphine, given its rapid onset of action, lack of histamine release, and lack of active metabolites. For sedative agent, as I said just now, non-benzodiazepine is preferred if patients is hemodynamically stable, because in patients with renal insufficiency, the effects of midazolam will be prolonged due to the accumulation of the active metabolites. So a protocol can help in implementing effective sedation management in ED. This is an example of sedation pathway taken from this table. So according to this pathway, whenever possible, we should prepare our propofol and fentanyl infusion before intubation. Immediately right after intubation, the infusions of the fentanyl and propofol should be started and should be titrated to target RAS score of -2 to +1. And the bolus of fentanyl can be repeated if necessary, and the infusion is titrated to achieve the desired level of sedation. So if the patient is over-sedated, the infusion of fentanyl and propofol should be withheld, and until the RAS target of -2 to +1 is achieved, and to restart the infusions at 50% rate of previous rate. If the patient is under-sedated, so the sedation and analgesia should be titrated up and until it achieves the desired level and monitor. I think ED should have a sedation protocol designed according to local setting. So that's about the analgesia and sedation part. Let's move on to the second part of today's topic. It's on the supportive care of ventilated patients. It includes preventions of ventilator-associated pneumonia, prevention of stress ulcer, and prevention of venous thromboembolism. First, ventilator-associated pneumonia, VAP. It is defined as pneumonia that develops 48 hours after intubation. The incidence was up to 30%, and it can result in prolonged ventilation, increased ICU and hospital length of stay, increased mortality up to 50%. This is the pathogenesis of a VAP. So it's caused from the bacterial colonization of the aerodigestive tract, the ETT, the ventilator tubing, which leads to micro or macro aspirations of secretion into the lower airway and cause ventilator-associated pneumonia. The Institute for Health Improvement has created a VAP bundle to prevent VAP, and it was last updated in year 2012. In this bundle, the 5 measures consist of head of bed elevation, oral care with chlorhexidine, stress ulcer prophylaxis, daily sedation assessment and spontaneous breathing trial, and DVD prophylaxis. Since the introductions of the VAP bundle, many centers have developed their own local protocols and guidelines, include additional measures in the bundle. Although they differ in components, the guideline generally follows the principle in VAP prevention, which are: number 1, prevent colonization; number 2, prevent microaspiration; number 3, prevent contaminations of equipment; and number 4, minimize durations of invasive ventilation. First, to prevent colonization, secretion clearance by frequent and regular oral and ETD suction reduce bacterial colonization. Previously, it is recommended to provide oral care with chlorhexidine. Recent evidence show that oral care with chlorhexidine may be associated with higher incidence of VAP and increased mortality. The possible mechanisms are that chlorhexidine causes oral mucosal damage and lung injury after expiration, and chlorhexidine may promote bacterial resistance. In animal studies, gross aspirations of chlorhexidine can cause ARDS. So further study is needed to provide us more evidence on the recommendations of use of chlorhexidine for oral care. Second, to prevent microaspiration, head of bed elevation, avoid gastric overdistension, ensure the ETT cuff pressure of 25 to 30 centimeter water, and subglottic suction have been demonstrated in studies to prevent microaspiration and reduce incidence of VAP. Third is to prevent contaminations of equipment. Standard hand hygiene is very important, and we also should minimize disconnection of the ventilator circuit and also reduce the circuit change, because this is this will increase the risk of VAP invasion. Disconnecting the circuit during open suction can cause bacterial colonization in the EDT by the contaminated suction catheter, and this can put patient at risk of VAP. Therefore, closed suction should be performed, and the ventilator circuit should be only changed if it is soiled, if it's wet. Last one is to minimize durations of invasive ventilation. Lung protective strategy should be practiced because injured lung has higher risk of getting infection. Early extubation is associated with lower incidence of VAP. So daily interruption of sedation, daily weaning assessment can help to expedite early extubation. What about VAP bundle in ED? Although VAP is generally diagnosed in ICU, the risk of developing VAP begins at the time of intubation. So the risk starts in ED if the patient is intubated in ED. So would introducing the same practice, the same VAP bundle to ED, reduce the VAP incidence? In this study conducted by DeLuca, looking at the impact of the implementation's VAP bundle in ICU and implementation in ED. The study showed that there was significant reduction in overall VAP incident and reduction in early onset VAP with the initiation of the bundle in ED. So the VAP bundle should be started in ED as well. If you see that most of them are simple measures which is doable, feasible in ED. For example, suction, elevate the head of bed, hand hygiene. But the awareness must be raised to habitualize this into the routine care of ventilated patients. Although most patients intubated in ED are not suitable candidates for extubation, but daily assessment of sedation is required to titrate the sedation. And daily weaning assessment should also be done in patients staying long period of time in ED. Next is the stress ulcer prophylaxis. Endoscopic study show 75 to 100% of patients develop stress ulcer within 24 hours of ICU admission. And clinical significant gastric bleeding is about 3 to 4%. Generally, proton pump inhibitor, histamine receptor antagonist has been shown to reduce incidence of gastric bleeding. However, meta-analysis on the efficacy and safety of stress ulcer prophylaxis show that stress ulcer prophylaxis alters the gastric juice pH, and this will promote bacterial colonization and is associated with increased risk of VAP and Clostridium difficile enterocolitis. Therefore, routine stress ulcer prophylaxis is not recommended. But it should be given to patients with coagulopathy, patient with history of GI bleeding, gastritis, peptic ulcer within prior year, patient who is ventilated for more than 48 hours, patient with 2 or more of the following, which are sepsis, renal failure, hypertension, severe head injury, and steroid use. Last is venous thromboembolism prevention. Study has shown up to 80% of critically ill patients without thromboprophylaxis may develop venous thromboembolism. And ventilated patients are at greatest risk of venous thromboembolism. The factors contributing to the risk include prolonged immobility, sedation use, neuromuscular blockage use. American College of Chest Physicians guideline recommend routine evaluations of VTE risk and thromboprophylaxis for critically ill patients. And thromboprophylaxis also recommended for acutely ill hospitalized medical patients who are at increased risk of thrombosis. And this can be done with low molecular weight heparin, unfractionated heparin, or fondaparinux. If the patients are at greater risk of bleeding, mechanical method is recommended. for prophylaxis. So we need to assess the VTE risk in ventilated patient, and we should initiate the prophylaxis in ED if it's not contraindicated. So this picture is taken from our Malaysia CBG guideline. It shows the risk factors for the venous thromboembolism, and here is the criteria of the patients who required or who should be started on prophylaxis. In conclusion, management of mechanically ventilated patients in ED have downstream consequences in patients' outcome. We should provide appropriate pain control and sedation. We should avoid early deep sedation. And VAP prevention bundle, stress ulcer, and venous thromboembolism prophylaxis should be started in ED also. With that, thank you.
Splendid.
Neccs? Wow. Exciting, man.